Good afternoon, Dr. Rakesh.
Good afternoon.
Good afternoon, sir. Welcome.
Thank you so much, Aru.
We'll be starting in another 5-7 minutes.
Yeah. I am already, I think, clicked in and waiting for Dr. The reading. The first session is regarding the back seat of surgery. Am I right?
Yes, sir. So I think I can see Dr. Ramakant Deshpande is also here. So in another 5-6 minutes, and we will start well on time.
It's a new way of now entering into a virtual meetings.
Yes, sir. So in fact, till now we were in Hall A. So there is a session going on the management of solitary pulmonary nodule. So there is a panel discussion going on. So we were attending that, and now we are sort of coming into Hall B.
Very nicely arranged, and repeatedly you people have been sending to all the participants the videos how to click in, so it became all ingrained in our minds. It was not difficult at all.
Yes, sir. And in fact, after this session, sir, at 5 o'clock, please join in Hall A for the keynote lecture. From 5 to 6, there will be a common session in Hall A.
I have opened the copy of this program with me already.
So at 5 o'clock, you can, join Hall A, and there will be having.
I have to exit from here and again re-enter in Hall A?
Yes, sir.
Okay. With the same password?
Same password, yes, sir.
Thank you. So we have two keynote addresses there. One is on the invasiveness of minimal access surgery, and second on knife versus X-knife.
Yes, sir. Yes.
That's fine.
Good afternoon, everyone. So welcome to the second day of NALSICON 2020. This is Hall B. I am Dr. Prekshi Chaudhary, and we will be starting with the next session at 4:30 p.m. So before that, I will like to invite the chairpersons for the next sessions, who are none other than Dr. Rakesh Kapoor. Sir is an associate professor at PGI Chandigarh, and Dr. Harit Chaturvedi.
Hari Charu, I am not in PGI now. I am professor of radiation oncology, but rightly director at TMC centers, both Homi Cancer Center, Tata Memorial, both at Chandigarh, New Chandigarh and at Sangrur. So I am the director of both these institutes.
Great, great.
I have been
sorry, Prekshi ma'am, I'm from backend team. So we are going live, right?
Another 4 minutes.
Yes. That's why I'm asking, ma'am.
Yeah, Parekshi, it's 4:27. Another 3-4 minutes, and then we start.
Yes,
Okay,
we starting. So before that, can the chairpersons? I will invite the chairpersons, and they will invite the speaker. So we can sharply start at 4:30. Is it possible?
Ma'am, actually, in the platform we are feed by whole A. So we are not live on B, whole B.
Okay. So we have to start at 4:30 itself.
Yes,
right?
ma'am.
Want to start at 4:30. That's right.
Okay. So I'll again start at 4:30. Okay.
Good afternoon, Dr. Ramakant Deshpande, sir. Good afternoon, Dr. Harit, sir.
Good afternoon, Harit.
Hi, boss. Good afternoon.
कैसे हो आप? राकेश जी नमस्कार.
sir, good afternoon. Welcome.
Thank you, sir.
Good
Thank you very
afternoon,
much.
Dr. Harit.
Yes, sir. Good afternoon. कैसे हैं sir?
Fine. How is everything in Delhi?
Delhi is swamped by corona completely. Absolutely.
Here in
Bombay
Punjab.
is worst. Is that right, Dr. Deshpande?
We are all competing with each other, I think, in this.
Yeah. It's really bad. Really bad.
Absolutely.
And again, ICUs are full, everything. But last 1 week, there's some downward trend, some relief. We don't know where it will go finally.
वो दो हर हफ्ते में ऐसे ऊपर नीचे चलता रहेगा ये तो.
That's true.
Welcome, Dr. Rambha Pandey and Dr. Saman Malik from Kolkata.
Good afternoon, Dr. Ramba. Good afternoon.
Good afternoon, sir. Good afternoon, ma'am. Good
Good
afternoon,
afternoon.
everyone.
This virtual platform will really grow exponentially, because even when the real world will come back, even then I think virtual connectivity will remain the backbone now.
That's right. I think it actually widens the horizon straight away.
Absolutely.
We were actually discussing about this Indian Society of Thoracic Surgeons meeting coming, which was supposed to be in January, February, and finally we had to. Obviously, you can't hold it in person. So going on virtual platform, suddenly we realized that our membership is 250, but last time 180 people were there. And when we started looking at the options, suddenly the attendance is going upwards of 500.
Yeah.
So it really makes it opens up the whole world, to be honest.
So this year for ISSLC, this particular NALCICon, we have got now close to 1,500 registrations.
Absolutely right. So not only that ISSLC members will come, but even the non-members also, so many people who wanted to attend and who couldn't physically come also will start attending.
The
That's
cost goes down, connectivity goes up, the faculty comfort is so much.
TMC Chandigarh and New
You
Chandigarh.
can't imagine doing a meeting and then going for your
Sangrur जगह का नाम है.
Yeah.
Chandigarh and Sangrur TMC. हाँ चलेगा TMC Chandigarh. हाँ.
Charu, your speaker is on. Yeah.
Now we can start live.
Okay.
Sure.
The chairman needs to call in the meeting.
Dr. Parekshi, you can start now.
You can start now. Yeah.
Request Dr. Rakesh Kapoor and Dr. Harit to start the meeting for the day.
Okay, Shubham. Thank you very much. I think we can straight away go ahead with this program. Dr. Deshpande Dr. Rakesh Kapoor is my co-chair, and as he just now cleared that he has moved from PGI, and at present he's in TMC, covering both the center at Chandigarh and also one in
Sangrur.
Sangrur. That's
Sir,
right.
it is Punjab centers now. There are 2 centers in Punjab. One is in Sangrur and other at Chandigarh. Mulampur actually, New Chandigarh.
So he's heading both the departments there, and it's a pleasure to have you here, sir, Dr. Kapoor. And we can start with the talk by Dr. Raman Deshpande, because he actually needs no introduction to this audience, or to, for that matter, to any oncology community, at least in India. And there cannot be a better person than him to talk about looking back to find a way forward, why surgery for lung cancer has lagged behind in India. So he has an experience of more than 35 years in surgical oncology, focused so much on thoracic work that his name is almost synonymous with lung cancer and lung cancer surgery in India. So Dr. Raman Deshpande, please, it's our pleasure to have you with us, and you can start your presentation.
Thank you, Harit, and thank you, Rakesh ji. At the outset, thank you very much for the organizers for letting me share my views here. It was in 1988, actually, when I was in the staff in Tata Memorial Hospital, when we actually first analyzed the past work of resections for lung cancer in Tata Memorial Hospital starting from 1946. The center started in 41. We could not get the older data, but 46 onwards, we started analyzing. And from 46 to 1988, we could just identify 188 resection patients. I'm sure there must have been more, but not too many more, maybe 250, maybe 300. But that is the kind of resection that used to happen. And mind you, this is in the country's premier cancer center. So from that is why the whole problem actually was being focused. Those days, actually, except for Delhi, Mumbai, Chennai, there was hardly any thoracic surgery which was being done at all. And lung surgery particularly lagged behind. So today, when the organizers asked me to look back to find a way forward for why surgery for lung cancer lags behind in India, I think it's a very, very valid point that they have actually taken. So, so that is what is important. Can I have my slides, please?
With somebody, yeah.
Okay. All right. So what makes for a surgeon? As you understand, when we start doing our MBBS or this thing post-graduation, not everybody can actually walk into the operation theater and have an appetite for that. Some people make excellent physicians, some people make excellent diagnosticians, some other people make excellent radiation therapists. Now, I do not have an appetite to become a radiation oncologist or physician, because the qualities which are really needed for that is totally different. What does a surgeon really need? You need to have a high degree of manual dexterity, good hand-eye coordination, excellent vision and visuospatial awareness, at least a correctable vision. You can't really be weak in your eye and be an excellent surgeon. That's going to be difficult. Good organizational ability to lead your team, because you always have a couple of surgical assistants, the nurses, the anesthetists, everybody, and you're the captain of the ship. And quite often it's your ability which will either sink or float the ship. Excellent communication skills to deal with a wide variety of colleagues, patients, and their families, ability to explain, ability to open the diagnosis to them, take them through the diagrammatic representation of what you are actually targeting to do, and then recapitulate the whole thing when the surgery is done. A good emotional resilience. You will go through an ups and downs tremendously. The patient does have an effect of the disease. He will have the effect of the surgery that you're going to do. And you need to take it with a calm temperament and an ability to work well under pressure. Very important. Patient is bleeding on the table. If you start throwing instruments around, you're not going to make a good surgeon at all. So physical stamina also to cope with the demands of surgery. In fact, some of the senior surgical writers mention that you should actually have a physical trainer if you want to really become a good surgeon. So I think that's taking it to too much of this thing, but I'm sure Max will definitely put somebody for Harit, considering that he's a star champion there. But suffice it to say that you need to be physically fit and the ability to lead and manage a team. Where do we really go? Why is it thoracic cancers are important? Let's just take a view at this Globocan 2018 India fact sheet. Out of 11,57,000 new cancer patients in 2018, 10.81% were thoracic cancers, and out of which practically 6% were lung cancers. So that is the kind of numbers and this number is going to increase practically almost 2 to 3 times. In our penchant to become developed country, please remember that we are also importing their diseases. So 67,795 new cancer cases 2 years back. And at the same year, 63,000 died. These are not the same patient who were diagnosed, but it means that you're dealing with an enemy which practically takes no prisoners. So when you are doing something like this, you have to have a certain amount of proper attitude. And why is it really important? India is already on the way to take over the position of being the most populous country. Probably, I think this year or next year, we are going to beat China as far as being very populous, not a record that we should be very proud about. And 3 of the 6 top causes of death are from respiratory disease. Cancer lung is rising very fast, as I mentioned, and just in many centers, it as a single organ, largest presentation of malignancy in many cancer registries, apart from being the foremost cause of cancer mortality in the Indian males. Tuberculosis is on the rise with multi-drug resistant tuberculosis raising its ugly head, so lung surgery becomes much more important. And 3 times as many patients as lung cancer are seen in the chest. Now, why exactly do we really get into a problem with poor results that what we have? If you really see a stage 1 lung cancer, now fortunately they have started dividing it into T1A, B, C, saying from 1 centimeter, 2 centimeter, 3 centimeter. Just 10 years back, when you would see a T1, N0, M0 survival in India, vis-a-vis the survival in Japan, our survivals would be 60% and their survivals would be 93%. The reason was most of our stage 1 were 3 centimeters. We had to beat them down to fit into the 3 centimeter size. So there was a late presentation. The reason is the common symptoms took them somewhere else, not necessarily to a common surgeon. So you have a cough, you go to a pulmonologist, you have a change in voice, you go to an ENT surgeon, so on and so forth. There are attitudinal problems. If a patient comes to a pulmonologist with a lung lesion, which is not very classical, he would treat the patient with anti-tuberculous line of treatment for a few months before he realizes what he's dealing with and then hand over the patient. Lack of awareness itself, that people would not realize that what they are dealing is a very lethal kind of a disease, particularly if the symptoms are not very severe. Logistic problems, that is, the patient may not be able to reach the proper center because of distance, because of monetary problems, and so on and so forth. There could be fear, ignorance, or superstition. And of course, finally, sahab paisa nahi hai. So this would be actually a reason for late presentation. Manpower, again, we will take it up because, what is happening is when you do a lung surgery, it is not only the surgeon who is important. It is also the supportive staff. If a nurse goes up, your results are not going to be as good. The strength of a chain is equal to the weakest link of the chain. A good ICU is absolutely necessary. You have to be able to rely on your ICU people for a bronchoscopy, for a tracheostomy, for the ventilation pressures, the CPAP, the BiPAP, the minimum pressures, etc. Physiotherapists are equally important. Pulmonologists have to take the baton forward. So it's extremely important to realize that every person is very important. Affordability, it's a long drawn surgery, needs blood, staplers, clips, endoscopic equipment, robos, sometimes very, very expensive as compared to any other branch of surgery. The training opportunities, till I think a few years back, there were only 2 or 3 DNB thoracic courses. There were no MCH thoracic courses at all. Even today, if you really see post-graduation in thoracic means there is cardiothoracic people. And the cardiac part is always more attractive for a cardiothoracic postgraduate. So social issues is, how can you operate a lung cancer? It can't be cured. Why operate it at all? And finally, there are hospital systems. So these are all the challenges. So let's visit them one by one. The desired doctor population ratio of 1:1,000 is not yet reached fully by India, but we are very much in line with that because of the medical college, almost 479 medical colleges with nearly 70,000 MBBS graduates coming out every year. Hopefully, in a few years, we would actually reach this unless our population growth overtakes that. But there is a skewed distribution among states. I'll just show you how exactly it happens. And whenever you go for your MCH cardiothoracic, there is hardly any stress over thoracic surgery. I mean, we would get at Tata Memorial Hospital or wherever, people coming in out of 3 years, they would come there for maybe 1 month, maybe 2 months for thoracic training. That is not really adequate. This is very, very important. And there are practically no or very few dedicated thoracic surgery training centers in the entire country with 138 crore population today. So anybody who wants to go into thoracic will certainly have an anxiety opting for that career prospect. So look at this. Actually, you will find that Sikkim has got the best doctor population ratio, the very best one. And then it is West Bengal, Karnataka, Goa, and so on and so forth. But more than 50% of our country doesn't really have adequate number of doctors. Affordability, which is abysmally low, 2.2 to 4% of GDP spent on healthcare, doesn't really speak very high of our healthcare spend and overall. Over 60% of healthcare spending is still on individual saving. So when you say that in a malignancy, breast cancer may take 2 to 4 lakhs of rupees for surgical treatment, the same thing as far as lung cancer is concerned will easily double up. With the 5 to 10% incidence of complications, even in the best of the hands, raises costs humongously. That 7-8 lakhs rupees can become 25 lakhs in no time. And then there are other options. The video assisted thoracoscopy surgery can actually cost because of the staplers, etc. And patients lose out on technology like VATS due to increased cost issues, and particularly the robotic option, etc. Then training is, in fact, it's so challenging that many of these cardiothoracic MCH positions have actually gone unfilled in the last few years because there's too much of grunge work, too much of the leg work, too much of waiting time, too few opportunities for these people. And then at the end of it, you may work, if somebody comes with Harit today and gets trained for 3 years, he should have an ability to give them an MCH a degree, which actually entitles them for consultants post elsewhere. That is going to be very difficult as it stands today. The length of training is very difficult. The training paradigms are not very, very clear. And one more thing is there is extreme hierarchical nature of most practice positions. This is very, very important. We are still almost into a European structure, unlike an American structure, where people can rise to positions in a much earlier age. We all have had to wait till our late 40s, early 50s to become head of the departments. Now, please understand, head of department, it is not like a temple where the older a stone, the more worshipped it is. It should not be like that. You are able to deliver, you have the knowledge, you have the capacity, you have been certified by people. I think you should be able to take a particular position. Secondly, what is happening is today what happened to the United States in the 1980s, where the insurance companies started dictating terms. It came to such a time that a consulting fee was $3 for an antenatal checkup for a patient. So it was no more very interesting for people to get into obstetrics and gynecology. And the same thing is happening to these hard, challenging kind of surgical lines. So there's a tremendously reduced remuneration per case, secondary to proliferation of public health schemes. Now, cancer lung treatment in our health scheme of the national health scheme, 23,000 rupees, do a lobectomy, including your staplers. I mean, how do you really fit into that? There are social issues like social stigma is still attached to both tuberculosis as well as cancer. Often families actually request that, Dr. Saab, inko aap nahi bataiye ki inko cancer hai. So we still are very afraid to accept the truth of diagnosis, the truth. We keep on being proud of an Indian heritage, Hindu culture, as what we call it as, that we accept everything that is there. We don't really accept things the way a Western population. If you give them a diagnosis, his next question is, doc, how long do I have to live? So that is the kind of a thing which is there. So this needs a certain amount of.
You have just 2 minutes with you now.
So there are hospital systems. India lags behind through EMR is slowly gaining ground. There's loss of valuable data, and real tumor boards are very important. But wherever you have a problem, you have a solution. So tremendous opportunity to increase both qualification and performance of allied health workers, etc. are there. Increased compensation, along with thoracic surgeon, concentration on allied and important branches can be done. We have 220 national cancer grid centers. They can actually become training centers. Opportunities for innovation with worldwide applications can come in. Techniques to minimize stapler use can be done. Reusing disposable instruments, standardization needs to be done. Development of low-cost instruments. Can we develop a robo at a low cost? Okay, draw on the power of CSR funds at every center. So the paradigm change is going to come from training opportunities. Improve the natural exposure of everybody. Even schools showing the excellent result that surgery can achieve. evolve mentorship programs, try and develop training programs at every step. We need to have good thoracic oncosurgeons. We train them first in thoracic surgery, have regular CMEs, improve the social factors, increase awareness that yes, cancer of the lung can be treated. If a screening is done, we can actually catch more number of patients in early stage, and increased efforts for health insurance by the government. Make the vehicle strong. The hospital systems need to be strengthened. EMR and data collection to show the exact status of our results. National Cancer Registry is already there, needs to be reinforced. Digital imaging access and PACS. And if it's difficult to have tumor boards in person, like what we are discussing right now, let us have virtual tumor boards that can be implemented. These are the factors. Thank you.
Thank you, Dr. Raman Deshpande, for this really an experience of kind that in per year average before 1988 was 3 cases per year at Tata Memorial Hospital. So you can imagine what the status was. I think they are not allowing any questions. We'll go ahead with the next talk by Dr. Ramba Pandey. She is the Associate Professor at IRCH AIMS in Radiation Oncology, and she's going to give us a radiation oncologist perspective on multimodal treatment of lung cancer. Dr. Ramba, please.
Thank you, sir. And thank you, Charu ma'am, for the invite. So, can I have my slides or I'll share myself? So is it visible to everyone?
Yes.
Ramba, you can carry on.
You need
Yes.
to make it full screen, ma'am.
Thank you, sir.
Go to the full slideshow.
I think it's not going on the slides here mode. I'll start presenting.
Sure.
So I'll be discussing the role of radiotherapy in the non-small cell lung cancer, especially the adjuvant radiotherapy in the non-small cell lung cancer. So as we all know that standard of care for stage 1 and stage 2 non-small cell lung cancer is a complete surgical resection with possible addition of adjuvant chemotherapy. For stage 3, significant controversies exist regarding the optimal management. For select stage 3A with resectable disease, NSCT or NACT followed by RT can be used. For unresectable stage 3 disease, concurrent chemoradiotherapy is usually given for the fit patient and sequential chemotherapy and radiotherapy for those who cannot tolerate concurrent chemoradiation. For stage 4 disease, systemic chemotherapy or urgent palliative radiotherapy for symptomatic metastasis or local disease is offered. So what is the rationale for giving the adjuvant therapy? So we all know that non-small cell lung cancer constitutes approximately 80% of the lung cancer, and most long-term survivors are those patients who had complete surgical resection. However, complete surgical resection can be achieved in about 30% of cases only, and that too in India, as most of the patients present in advanced stage, surgical resection is possible in about 10% of patients only.
Rama, sorry for interrupt. Can you share your slide in full view?
Sir, I'm trying, but it's not.
Rama, just go to the bottom, and here you can see there is this for full slide.
Yes,
yes, ma'am. Thank you, ma'am.
Yes. So even with surgical dissection, complete surgical dissection, there is always a risk of loco-regional or distant recurrence, and this incidence is to the tune of 20% in stage 1 completely surgically resected patient, and it can go up to 50% in stage 2 patients. We all know that the most common site for intrathoracic failure after surgical resection is along the surgical span and in the mediastinal node. In stage 3A and selected stage 3B patients, The 5-year survival is to the tune of 20 to 25%. And also there's very high risk of metastatic or local recurrence. Distant failure is to the tune of 30 to 50%, and brain metastasis can occur in 20 to 32% of patients. Local failure rate at 3 years in surgical series varies from 15 to 40%, and in the chemoradiotherapy series, local regional progression rate is around 30%. So as there is a very high risk of loco-regional recurrence or distant metastasis, there is a need for adjuvant treatments such as chemotherapy or radiotherapy, and it has been evaluated in order to improve the prognosis in non-small cell lung cancer. So what is the evidence in favor of post-op radiotherapy? So the first landmark trial, which was a meta-analysis by non-small cell lung cancer collaborative group published in BMJ in 1995. This was basically a trial to show the role of adjuvant cisplatin in non-small cell lung cancer, and it showed absolute survival benefit of 5% with addition of cisplatin-based chemotherapy in completely surgically resected non-small cell lung cancer. However, despite this, the local tumor failure, even with surgery and adjuvant chemotherapy, was to the tune of 20 to 40%, and hence there was a need for further local therapy, and role of post-op radiotherapy was evaluated. Now, these were the retrospective studies on post-operative radiotherapy before 1995, and most of the study, they have used radiotherapy to the dose of 40 gray to 66 gray, and some of the trials have actually shown very good results with addition of post-operative radiotherapy to the tune. Maximum was seen in the study by the Patterson et al., where 5-year actual survival was 56%. So these study formed the basis for the further study on the role of adjuvant radiotherapy in the non-small cell lung cancer, and the landmark trial was Port meta-analysis of Medical Research Council, which was published in Lancet 1998. This trial included 2,128 patients from 9 trials, and the median follow-up was 3.9 years. This trial showed significant adverse effect of post-op radiotherapy on survival, with 21% relative increase in the risk of death. This was equivalent to absolute detriment of 7% at 2 years, reducing the overall survival from 55% to 48%. The subgroup analysis suggested that detrimental effect was more pronounced for patients with stage 1 to 2 N0, N1 disease, whereas for stage 3 N2 patient, there was no clear evidence of an adverse effect. There was certain criticism to this study that 25% of patients who had PN0 disease actually did not need adjuvant radiotherapy. There was no quality control in the radiotherapy arm, and it was felt to be inferior to the modern standard. Most of the patients were treated to target volume using older cobalt-60 equipment to field designed under fluoroscopy, and the detriment in overall survival seen with post-op radiotherapy was felt largely due to excessive late toxicity to normal tissue, particularly the heart and the lungs. So this trial it was disappointing from the point of view of a radiation oncologist. So, and in this trial, nine trials were included, and now after this trial, there was an updated analysis of this by the same group, and in this trial, they included one Italian trial also. So the previous Port analysis, they had included 9 trials, but in this study, they included 10 trials, one from the Italy as well. And this trial was published in Lung Cancer 2005, and this showed that this again showed Port to be detrimental with 18% relative increase in the risk of death. Port was more harmful in stage 1 than in stage 2. However, there was some relief from the radiation oncologist point of view, that the SEER analysis, which was published in Journal of Clinical Oncology in 2006. This SEER analysis included 7,400 patients with stage 2 and 3 resected non-small cell lung cancer. In this analysis, Port showed improved 5-year overall survival for pathologically N2 patient, 27 versus 20% in favor of post-operative radiotherapy. However, this study also showed reduced overall survival for pathologically N0 and pathologically N1 disease. Now, this ANITA trial, this trial was basically a chemotherapy trial, and this trial was intended to assess the efficacy of cisplatin and vinorelbine in adjuvant setting in a patient with non-small cell lung cancer of stage 1B to 3A post-surgery. So this trial included 840 patients, and all these patients post-surgery, they were randomized to receive chemotherapy, cisplatin and vinorelbine, or no chemotherapy. Radiation was at the discretion of the treating site. The result of this study was published in 2006 in Lancet Oncology, and this study showed that overall survival at 5 years with chemotherapy improved by 8.6%, which was maintained at 7 years. A subset analysis of this ANITA trial, which was published in IGROBP in 2008, showed that patients with PN2 disease who received post-operative radiotherapy, both in the chemotherapy arm or in the observation arm, has a improvement in the median survival from 23.8% to 23.8 months to 47.4 months in favor of post-operative radiotherapy, and in observation arm 12.7 to 22.7 months in favor of post-operative therapy. So this retrospective evaluation suggests a positive effect of PORT in pathologically N2 disease and a negative effect on pathologically N1 disease when patients receive adjuvant chemotherapy. Now, so far there was no randomized trial, and this was a phase 2 trial by RTOG group, RTOG 9705, which was published in Journal of Clinical Oncology in 2005. And this trial was a phase 2 study assessing the efficacy of adjuvant paclitaxel and carboplatin along with thoracic radiotherapy in resected stage 2 and 3 in non-small cell lung cancer. This study showed a median overall survival time was 56.3 months with 1, 2, and 3 year survival rate of 86%, 70, and 61% in post-op radiotherapy arm, and progression-free improvement in progression-free survival with 1, 2, and 3 year progression-free survival rate being 70%, 57, and 50%. And the result of this study was comparable to Eastern Cooperative Oncology Group 3590. So this result showed an improved overall survival and progression-free survival in the group of patients who received post-operative radiotherapy or adjuvant treatment. So over the period, because all these studies were meta-analysis or SEER analysis, over the period there was a need for assessing the role of radiotherapy in the non-small cell lung cancer. So this was a study by Corso et al., which was published in JTO in 2015. And this is basically included patients from the National Cancer Database. So this study included 30,552 patients treated between 1998 and 2006. In this study also, it was shown that addition of post-operative radiotherapy has favorable effect on the N2 disease, a patient with N2 disease. The 5-year overall survival increased from 27.8% to 34.1%. However, this was detrimental in patient with N0 disease and N1 disease.
Dr. Ramba, 2 more minutes.
Yes, sir. Now, role of radiotherapy in patient with incompletely resected lung cancer. So this was again assessed in a study by post-operative radiation therapy is associated with improved overall survival in completely resected stage 2 and 3 non-small cell lung cancer patient, was published in JCO by Wong et al. And this study showed that PORT is significantly associated with improved survival in patient with incompletely resected stage 2 or 3 N0, N2 non-small cell lung cancer. These are the Kaplan-Meier survival curve for patient in this study, and it shows that in all stages, patient with positive margin, there was improvement with the addition of the post-operative radiotherapy. Now the lung art trial, this is the most awaited trial, and This trial basically is intended to assess the efficacy of post-operative radiotherapy in completely resected non-small cell lung cancer with proven N2 disease. And the study was intended to include 700 patients to show a 10% disease-free survival difference at 3 years. So in this study, the patients were randomized to receive no mediastinal RT or conformal mediastinal post-operative radiotherapy, 54 gain 27 fraction to 30 fraction. So recently, the primary endpoint analysis of lung art trial was presented at ESMO 2020 on 20th September 2020. In this analysis, they included 501 patients. In post-operative arm, there was 252 patients, control arm 249 patients. Safety analysis was carried out in 487 patients. So this study shows that disease-free survival or overall survival does not improve with the addition of the port in non-small cell lung cancer. So to conclude, the authors commented that post-operative radiotherapy can be recommended for all patients with mediastinal nodal invasion. This is useful for some patients as it reduces the mediastinal relapse by 50%. So in summary, the indication for post-operative radiotherapy remains stage 1 and 2 with closed or positive surgical margin. In stage 3A, closed margin, positive margin, N2 disease and nodal extracapsular extension may be controversial after the lung art trial. So to conclude, the RT plays an important role as an adjuvant modality in close or positive margin in stage 1 to 3A non-small cell lung cancer. The interim analysis of lung art trial shows post-operative therapy cannot be recommended for all patients with mediastinal nodal disease. It can be included judiciously for patients with high-risk disease. The final result of lung art trial may have an impact on role of post-operative radiotherapy in N2 nodal disease. Thank you.
Thank you, Dr. Ramba. I think I can't see any questions, Dr. Harita, on the screen. But,
So there is a question, if I can quickly take it in the chat box. So the question is, what is your take on post-op, your experience of post-op RT, Dr. Ramba? And if a patient is a N2 at presentation, given NACT, then surgery done, and now there are no pathological nodes, would you advise post-op RT in such a case?
Actually, so far we are practicing the that we give in post-operative radiotherapy in N2 disease, and we have not seen any recurrence in patients who have been treated with post-operative radiotherapy, though we have not very large data to support this, because most of the patients who come to radiotherapy, either they have the surgically positive margin or N2 disease. So in these patients, definitely there is a role of post-operative radiotherapy so far, unless the lung art trial complete result is there and they show that there is no advantage of giving post-operative radiotherapy. So far, we are practicing giving N2.
I think, Dr. Charu, to add to it, can I say something?
Sure, sir.
Yeah. I just want to clarify two things, because one is that what she has spoken is regarding the lung art trial. It is important for us in the lung cancer post-operative RT that what is the location of the tumor if we have to plan for a post-op RT. That is important. Number two, what is the actual respiratory reserve and the functions which were there in that patient, and any associated comorbidities. If comorbidities they were existing right from the beginning, or now you are planning for post-op RT. In fact, I was expecting, looking at the heading of this talk in the beginning, which is given in the brochure, I thought that there must have been something more related to the nodes from a surgical point of view, because Dr. Ramakant Pandey was there. Whether there is a node which is beyond the reflection once you do the surgery, the pleural reflection, those mediastinal groups should be included. For a post-op RT, those patients should be included or they should be excluded. As far as N1 disease is concerned, the controversy is by and large settled now. There is no added benefit to that. But N2 is a very crucial area for a post-op RT. And the second important point is regarding the sequence, whether you should do a sequential CTRT in these settings or you should do a concurrent, because in a non-inoperable patient now in 3B, 3C, it is beyond doubt that a concurrent chemoradiation is better as compared to sequential. But in post-operative setting, most of the patients don't tolerate such type of treatments. So we go ahead with a sequential as compared to the concurrent. Thank you so much.
Thank you, sir.
Thank you, Dr. Kapoor.
And what we would normally practice is here, if there is a positive margin, then we would like to do radiation first. If the patient is fit, then concurrent CT-RT. Otherwise, positive margins, radiation first, followed by chemo. And if positive nodes, then first chemo, then followed by radiation. So thank you, sir. Over to Dr. Parikshi.
Thank you, chairpersons, and thank you, speakers, for this wonderful academic piece. So now we will move to Hall A for 2 keynote lectures. And after that, we'll join back again at 6 p.m. for next sessions. So we have to move to Hall A.
Hello?
हेलो डॉक्टर आनंद।
हाँ जी।
हाँ जी, क्या हाल है?
आप सुनाइए।
बस चल रही है। मुझे लग रहा है यहाँ कुछ हो रहा होगा तो मैं
तो
मुझे
मुझे
लग
समझ नहीं
रहा
आ रहा, हम भी यही लेके बैठे हैं कि हमें हॉल भी तो दिखना चाहिए ना, जो अभी सेशन चल रहे हैं।
है हाँ, कुछ नहीं दिख रहा, मतलब दूसरी जगह है। मैं पहले
हाँ
हॉल ए में एंटर हुआ तो वहाँ चल रहा है एक सेशन।
हाँ। अब या तो इसको हम स्विच ऑफ करके फिर वहीं जाएं, पता नहीं।
हाँ वो ये
So we'll be shortly starting. If you want, you can attend Dr. Konibe's session, but we'll be starting in another 10 minutes over here, sir.
हाँ हाँ, चलो फिर यहीं वेट कर लेते हैं।
हाँ बट
10
दिस
मिनट्स में क्या है अच्छा, ये दिस इज गोइंग टू स्टार्ट इन 10 मिनट्स।
हाँ दैट
Yes,
इज,
sir. Yes, sir.
नहीं तो वहां से
चल
आगे में अगेन अलग कहीं ना कहीं मिस हो जाएगा।
हाँ। फिर कोई गलत बटन दब गया, फिर मुसीबत पड़ जाएगी, पहुंचेंगे नहीं यहाँ।
आजकल कोई भरोसा नहीं, टेक्नोलॉजी
कहेंगे जी आपने वो नहीं दबाया, वो कौन
Sir,
दबाएगा।
sir, sorry for interrupted, but you are live on Max Hospital page, web page, Facebook page.
ओके ओके ओके
अच्छा क्या कर-
Thank you.
ठीक
नहीं,
है,
पर
10
अब हम
मिनट
क्या
वेट कर
करेंगे, अभी
लेते
तो प्रोग्राम हैज नॉट स्टार्टेड।
हैं। वेट फॉर 10 मिनट चलेगा।
We'll need to wait, sir.
ओके।
अरे हमनाम नमस्कार।
हाँ जी, अच्छा आप भी पहुंच गए, वेरी गुड।
नमस्कार
हाँ,
नमस्कार
किधर
यार।
से किधर घूस के गली गली में आके पहुंच गए। फिर
आपको
टर्न
भी
राइट,
घूमना पड़ा।
टाइन लेफ्ट, टर्न राइट एंड देन गो स्ट्रेट।
अगर दिल्ली में आते सब लोग यही कहते सीधे चले जाइए, उनके लिए राइट लेफ्ट एंड सीधा, ऑल इज सीधा।
Yeah, this is really tough. And this is Hall A, Hall B, faculty launch, e-launch, वो launch.
हाँ,
So,
तो अभी आप लोगों की पिक्चर्स नहीं दिख रही है, हमें सिर्फ अपनी दिख रही है, क्या बात है भाई।
तो आप स्मार्ट है, आप दिखा रहे हैं, हम नहीं दिखा रहे बस।
नहीं, आप जब बैठते हैं तो पीछे से तो वाटरफॉल्स और सम रिवर्स और विजिबल, आज क्या दिखा रहे हो।
चलो दिखा दे रहा हूँ बस है।
हाँ, ये दैट इज द वन। यू आर सिटिंग इन गोवा।
Yeah.
नाइस, वेरी एयरी एंड ब्रीजी।
So, right. So, it's good to catch up with you, man. So, I mean,
हाँ,
too many webinars now, 6 to 7, again 7 to 8, one more. Oh my God. Early conferences were better here, at least spaced out.
yeah,
Webinars, they are not spacing out. It's too many webinars, too many
too
things.
many.
Mm.
You miss them, and then because they send a reminder, you forget. So there are too many things happening. और आपका कॉन्फ्रेंस का भी आया, कुछ कर रहे हैं आप लोग भी।
नहीं यार, हम कुछ नहीं कर रहे अभी। हम आई डू इट वंस इन 2 years एट कैंसर CI.
तो आया था आपके यहाँ से कुछ।
मीन अपोलो ग्रुप से कहीं आते रहता है, दैट इज ओके।
अच्छा।
तो जो आप हैदराबाद से जो करता हूँ तो आपको बिना मालूम हो कि तो होता ही नहीं वो। That happens once in 2 years. So that's fortunately वो फरवरी में हो गया, मार्च से लॉकडाउन शुरू हो गया। I was so lucky. I was so lucky, just finished off.
Yes, इतना सारा अरेंजमेंट एंड ऑल दैट।
वो अलग ही रहता है यार मीटिंग, you know, the webinars are very good to a certain extent, but nothing like meeting people in person and exchanging ideas. That's अभी webinars का attendance is coming down drastically.
Yeah. It's hard to concentrate because you have to look at a very small screen, and then you get tired. And we are not so much accustomed. We are not IT people who will be concentrating on the screen for a long time. That is the problem. Or how is Hyderabad doing now? Things are under control?
Yeah, very much under control. It has become, I mean, just new normal. People are just going around. Traffic फिर बढ़ गया है. But hospital attendance overall 25%, 30% come हुआ है. Going home by 5 o'clock now.
Yeah.
One way it is good.
Yes.
I don't know whether we'll go back to that 9 to 9 work. 11 hours work तो कर रहे थे, अभी तो कम हो गया है March से.
So if we don't change, nature makes you change.
Yeah, true.
Nature
Change for good. Change for good.
Good, yeah. Exactly.
So we now is a new life is actually looking much better. I was just thinking why the hell we were working so hard all these years.
Exactly. I completely agree.
I know.
That,
so actually, 25% income कम हुआ है, but actually 50% expenditure कम हुआ है.
Yeah.
Yeah. So पैसे कैसे भी बच रहे हैं, sir. You don't need that kind of money actually.
What is the need? We were just burning money, like, just for spending money, whether it was needed or not.
Yeah. So you're enjoying. Actually, I'm enjoying more than what it was before the lockdown.
Exactly.
So, the life was so fast. Monday आ रहा था, Saturday आ गया बस.
Exactly.
Without even realizing that bago.
Yeah. Exactly.
अब it's quite cool, calm. Golf खेलो, shuttle खेलो.
Yeah.
घर में खेलो, spend some time with spouse, घर पे बैठो, अच्छा.
And don't go to too many crowded areas.
Yeah, see, you work till 7:38 in the evening, and again there's an invitation to come for a party.
Yes.
Such a pain, So every week 3-4 parties bolte ki you get so tired.
Yeah.
Good evening, sir. So we'll be starting for the session for 6 p.m. shortly. May I request Dr. S.K. Sri Krishna and Dr. S.K. Srivastav, sir?
So S.K. Krishna from Bangalore and Srivastava from Mumbai and Vijay Anand Reddy from Hyderabad. So we are the 3 chairpersons. So it's
I also request the backend team to give the screen sharing rights to Dr. Suman Malik.
Good evening.
Please start the session,
Sorry, my video is not working, but I'll be able to coordinate verbally.
Okay. Backend team, you'll need to help Dr. Suman Malik for this presentation.
Sabre may have similar survival to surgery for medically operable stage 1 lung cancer, but I think only trials will tell whether that's the case.
Okay, sir.
I don't know.
We are good to start, Dr. Reddy. You may please.
All right.
Very wonderful lecture, and you have taken us through the history of.
So, Dr. Suman Malik, are you ready?
Yes, sir.
All right, wonderful. At the outset, thank you very much and for giving me this wonderful opportunity to be part of the show and welcome the co-chairpersons, Dr. S.K. Srivastava and Dr. S.K. Krishna from Bangalore. We all know that we are dealing with the lung cancers, and the most exciting part of the lung cancer is about stereotactic body radio surgery with radiation therapy. So we are going to deal with that in our session. It starts at 6 to 6:50 p.m. today. And the first talk is, we have an excellent team of speakers here. We have Dr. Suman Malik from Kolkata and Dr. Rajan from Chennai. That's going to be a debate on central tumors or SBRT versus sleeve resection. And then followed by my dear friend, Dr. Anand, is going to take us through functional lung imaging for radiotherapy, planning for lung cancer, followed by consolidating primary in metastatic non-small cell lung cancer, who, when, and how, by my colleague, Dr. Vinita Goel. So without much ado, let us start with the first fight. I would call it as a fight or a debate. Dr. Suman Malik, over to you. He's going to talk on role of SBRT for central tumor. Nice. You have 8 minutes to talk, and then 2 minutes for is it rebuttal or is it going to be a questionnaire? May I know? May I ask the organizers? The 2 minutes is for the rebuttal or is it for questionnaire?
The rebuttal.
Okay. Yes, Dr. Suman Malik. Over to you.
Yeah. Good evening, sir. Is my screen visible?
Yes.
Yeah.
Yeah. Good evening, everyone, and thanks for inviting me and giving me this opportunity to express my unbiased point of view on SBRT for central and ultracentral lung lesions.
It was not working.
So we know that SBRT is the standard of care for medically inoperable early stage lung cancer. And several retrospective data, phase 2 and phase 3 data have shown that 5-year local control rate with SBRT is between 70 to 90%, and with overall survival of 5 years between 50 to 70%. And there is also ongoing debate about the role of SBRT in medically fit and operable lung cancer
Please open
patients.
your camera, please.
Uh, just a moment. Now is it fine?
You are not visible. Your
So
screen is visible. Your slides are
yeah,
visible.
camera is on. So
You're absolutely blank.
okay. So shall I proceed?
Yeah, please go ahead. We have
Yeah.
time.
So two ambitious randomized trial actually tried to address this issue, but closed prematurely due to poor accrual. And the pooled analysis was published in Lancet Oncology 2015, combining the patient data of STARS and ROSEL. And out of 58 patients of pooled data, 31 patients actually received SABR and 28 patients actually had undergone surgery. So if we look at the outcome data, 1 year survival was 100% in SBRT versus 95% in surgical arm. 2 year survival was 88% in SBRT versus 79% in surgical arm. So authors summarize that SABR is better tolerated and might lead to better overall survival than surgery for operable clinical stage 1 NSCLC. And if we look the data closely, both the trials have also included the central disease. But the dose of the central tumor was different. It was 50 gray in 4 fractions.
I'll be on.
And after that, there are several studies. These are the ongoing studies, randomized trial, which are also looking at the surgery versus SBRT. So probably in next few years, we'll get the results of these studies. Now the problem is central tumors actually they behave differently that of peripheral tumor because they are very close to some important structures like central tracheobronchial tree. And this is the data from RTOG group by Dr. Timmerman. And he has shown that if we give the same dose to the central tumor, that may actually cause potential harm to the patient. And in this series, there was 27% of high grade 3 or more toxicity in those patients. And location was one of the important predictor for severe toxicity. So then the concept came as no-fly zone. Now the question is, can we, means the radiation oncologists, fly in a no-fly zone? So classically, we describe no-fly zone as a 2 centimeter from the proximal tracheobronchial tree, and that is known as the central group of tumors. And nowadays, we define as an ultracentral group when actually PTV overlaps with the proximal bronchial tree or esophagus. So this is known as ultracentral tumor. So there are several data, fewer retrospective, fewer prospective data for the ultracentral tumor as well. So if we look at the local control and OS, it is comparable with the peripheral tumors. But if we look at the toxicity, few of the studies have shown quite high toxicity, like from Tecatli and from MSKCC, they have shown very high toxicity rate for the central or ultracentral tumors. But if you look at the data from PMH or by Dr. Chaudhary et al., so they actually in their cohort of patient, there was no patient who had grade 3 or more toxicity. So the toxicity is variable. So there are some other factors which are working for this toxicity, and probably that is the dose. For this reason, RTOG 0813 was designed to look at the maximum tolerated dose for a central lung tumor. And they evaluated 120 patients, and they concluded that maximum tolerated dose was 60 gray in 5 fraction, that is 12 gray per fraction, and the probability of dose limiting toxicity was 7.2%, and only total 5% actually 5 patient actually experienced the dose limiting toxicity more than grade 3. And in this cohort, the 2-year local control rate was near about 90%, and 2-year OS was near about 70%. And if we look at the data more carefully, and there was significant proportion of the patient who had ultracentral disease. So 17 of these patients actually who received 60 gray total of full dose, they had a ultracentral disease, which means that probably that this dose fractionation is safe for ultracentral disease. So subsequent trial, it's a Canadian trial, which is the Sunset study. It has been designed to see the maximum tolerated dose for ultracentral tumor. The RTOG was the central and ultracentral. This is only for ultracentral tumor. So we are expecting the data to come in 22 after 2 to 3 years. And this is basically mathematical modeling. It has been done to see the which dose fractionation has a better tumor control vis-a-vis with a lesser toxicity profile based on the tumor control probability and normal tissue complication probability. And this model has shown that probably 60 gray in 8 fraction can offer a patient with maximum uncomplicated tumor control of about 53.5%. And same dose fractionation schedule was used in this prospective cohort by Zhao. It has been published this year only, and they have shown with 60 gray in 8 fraction for ultracentral lung tumor, we can achieve a 3 years local control rate of near about 85%. And if you look at the toxicity profile, so even for ultracentral lesion, it was less than 5%, and which was also true for the central tumor. So this is the Indian data we have from TMH. It's a long-term data, retrospective data. And if you look at the conclusion by Dr. Agarwal that location of the primary, peripheral versus central did not significantly affect the incidence of the radiation pneumonitis as well. So it's not about the location, it's about the dose that we should prescribe depending on the location of the tumor. That is important. So to conclude, we can say that SBRT lung is the standard of care as of now in inoperable early stage non-small cell lung cancer. Indications are expanding to even to those patients with operable lung lesions based on this pooled RCT data, and SBRT for ultracentral lung lesion is challenging definitely in terms of higher toxicity profile, but the recent data suggests that success of SBRT or SABR for ultracentral disease depends on choosing the right radiation dose fractionation. So thank you very much.
Thank you, Dr. Suman. Now, may I request Dr. Rajan Santosham from Chennai. He's a surgeon, cardiothoracic surgeon from Chennai. He is going to talk on the same sleeve resections in central tumors. Over to you, Dr. Rajan.
I'm fine. Can you hear me?
Yes, very much. And we can see you also.
Yeah. My slides are not opening as yet. Just give me a minute. Yeah.
Uniform.
Thank you for the invitation. I'll be speaking about sleeve resections. What is sleeve resection? The removal of a circular portion of the mainstem bronchus, trachea or lobar bronchus, usually in continuity with adjacent lung tissue. A portion of the mainstem bronchus or carina can also be removed as a sleeve without removing lung tissue. What are the indications? Tumors at the origin of lobar bronchus, carcinoma or bronchial adenoma, which precludes simple lobectomy, not requiring a pneumonectomy due to limited infiltration. Benign bronchial strictures related to trauma and inflammatory diseases, acute traumatic disruption of the airway. What is the goal? The main aim is achieving a complete resection of tumor with adequate margin-free tumor, oncologically sound resection, and lung tissue conservation. There are various sleeve procedures: tracheal sleeve, carinal sleeve, bronchial sleeve, and sleeve pneumonectomy. Steps in brief. Pulmonary sleeve resection can be broken down into a few general steps: dissection, exposure and judgment, isolation of vascular and airway structures, resection, airway and if necessary vascular anastomosis and closure. Immediate preoperative assessment, extent of disease assessed with a detailed review of the CT scan along with the radiologist, double lumen intubation, on-table peroperative bronchoscopy is very essential, especially in central airway tumors. Feasibility of sleeve resection decided by direct extension, involvement of adjacent structures, mediastinal nodes, and in selected cases, pleural or omental flap cover. Peroperative bronchoscopy is very useful, and we always use a bronchoscope to place a double lumen tube. The tracheal sleeve resections mainly have been done for tracheal stenosis and 99 cases for tumors: adenoid cystic carcinoma 24, glomus tumor 2, mucoepidermoid tumor 17, thyroid malignancies infiltrating the trachea 18, and carcinoid tumors 38. You can approach the trachea if it is in the neck by a cervical collar incision, and if it is about 2 centimeters above the carina by a cervico-median incision, and any tumor below 2 centimeters, less than 2 centimeters from the carina, I prefer a posterior lateral thoracotomy. Tracheal mobilization technique. Mobilization of upper trachea limited posteriorly to the cricothyroid junction. Anterior and post, because the recurrent laryngeal nerve enters there. Anterior and posterior mobilization to the lower trachea up to the carina, because the vessels come from the side. Too much of lateral dissection to be avoided. Hilar and inferior pulmonary ligament release. U-shaped incision of the pericardium around the inferior pulmonary. Anastomotic technique, use absorbable sutures 3-0 or 2-0, sometimes 2-0 according to the thickness of the trachea. Interrupted sutures And sometimes if the trachea is thin and supple, continuous sutures, anterior and posterior layers, airtight apposition, and a tension-free anastomosis. Mucoepidermoid carcinoma, 35-year-old male who came with severe stridor and treated as bronchial asthma for 6 years. This is a CT picture showing you a large tracheal mucoepidermoid carcinoma and pneumonitis on the right middle lobe bronchus because of infection. This is the operative picture of the tumor. You can see cross-field ventilation with a flexometallic tube distally. After segmental resection of the trachea, end-to-end anastomosis is being done. And this is a resected tumor. The section of the bronchus resected along with the lobe. Bronchial sleeve resection is a section of the bronchus resected along with the lobe. Distal and proximal bronchus, this then anastomosed with the main stem bronchus. There are different modifications as each case requires. These are the various types available of right upper lobe sleeve, right upper lobe and 6-segment sleeve, right upper lobe and 6-segment sleeve once again, and then together, and then left main bronchus sleeve, and here you can see the left main bronchus sleeve. CT scan of a bronchial tumor. CT scan once again of a bronchial tumor. Here you can see operative picture. Right thoracotomy is being done. You can see the superior vena cava. Yeah, you point. Superior vena cava, large acygos vein, and the trachea behind, and the lung to the right side. Now you can see the tumor, the trachea, right main bronchus and left main bronchus have been taped. You can see the trachea being cut from the carina to the origin of the right main bronchus. You can also see a part of the double lumen tube. And then you can see the bronchus intermedius being cut. You can see, and once you do this, you get a good sleeve all around. So if you do a regular lobectomy, you won't get a sleeve. And by a bronchial sleeve resection, you get good clearance. This is sutures have been taken from the cut end of the trachea and the bronchus intermedius, and the ties are tied intermittently without tension. And now we come to carinal sleeve resection. These are the various pictures of carinal sleeve resection. Our experience has been carinal left pneumonectomy 2 cases, carinal right pneumonectomy 2 cases, carinal resection for tumors 8 cases, carinal mobilization for low tracheal tumors 8, low tracheal stenosis 7 cases, and right-sided sleeve resection 8 cases, traumatic bronchial rupture in 8 cases. This is an example CT and a bronchoscopic picture of a carinal tumor, and a carinal carcinoid infiltrating the carina. The CT scan of the same patient showing that even the upper lobe is spared. And you can see the tumor is slightly extending onto the left main bronchus. Another CT scan of a typical carinal tumor. A detailed preoperative evaluation is mandatory. Preoperative.
If I may interrupt you, you know, we just want you to conclude on your point of view.
Yeah, I will do that. I've got 2-3 slides for that. I will conclude with that. Debulking of the tumor before surgery to establish the airway, careful intraoperative assessment before cutting the carina. You should not have 2 cut ends of the airway which cannot be anastomosed without tension. The various approaches to the carina. I prefer the right thoracotomy, ligating the acygos vein, dissecting the tracheoesophageal groove. Keep the dissection as close to the trachea to avoid injury to the recurrent nerve. Mobilize carina, right main bronchus and left main bronchus, like in this picture. Then the tumor can be seen, the carinal carcinoid here. You can see the U-shaped incision on the pericardium being made to release the carina up below the inferior pulmonary ligament behind the phrenic nerve. And the right inferior pulmonary ligament has to be released. Here is the here you can see pictures of carinal pneumonectomy, carinal right pneumonectomy and left pneumonectomy. This is an example of a carinal left pneumonectomy. Right thoracotomy done, carinal tumor excised, left main bronchus cut and closed, as in the second picture, the interrupted sutures, and open the left side and remove the left lung. Now, what is the central? He has already described the central and ultracentral tumors. In ultracentral tumors, if operable, because the higher toxicity of radiation, surgically, if feasible, that's very, very important. If feasible, if the patient is fit, if you know how to do the surgery, will be a good option. The other the ideal treatment of ultracentral tumor is surgical resection. Sleeve resection preserves lung parenchyma. Sleeve resection with systematic medical mediastinal lymphadenopathy gets complete resection with margins as well as evaluation of the mediastinum, which is proved as an oncologically sound procedure equivalent to disease-free and overall survival of lung cancer with better quality of life. SBRT is recommended for patients who are medically inoperable or who refuse to have surgery after evaluation. It is also appropriate option for patients with high surgical risk. Those who cannot tolerate a lobectomy or pneumonectomy due to poor lung function or cardiac function. Conclusion, sleeve resection is a technically demanding and challenging procedure, requires good coordination with the anesthetist and the team. It achieves preservation of lung tissue, especially in patients with compromised lung function, unsuitable for radical resection, especially in ultracentral tumors. Thank you.
Thank you, Dr. Rajan. May I request Dr. Suman to come back and just say a few words about what is your take on central tumors after Dr. Rajan's talk?
Yeah, I agree with sir that still we do not have strong evidence in favor of SBRT for central tumor or ultracentral tumor when the patient is suitable for surgery or medically operable. But now we are getting more data on ultracentral tumor. Probably in next few years, probably we'll be able to uh, uh, show the data that it is equally effective and equally and probably less toxic compared to the surgery. The only drawback of SBRT that we face that usually when we do SBRT, we don't get any histopathological data about the lymph node involvement or any extension of the tumor in the local site. Usually after surgery, often we see upstaging of the tumor. So, and based on the upstaging, usually sometimes we offer adjuvant therapy. But in case of SBRT, that scope is not there. But though, if you look at the data, if you look at the local control and overall survival, it is comparable.
Thank you, Dr. Suman. And Rajan, Dr. Rajan, you would like to say a word?
I think they are complementary to each other. In a young patient, fit patient with an ultracentral tumor, with no extension, when you know that you can definitely cut and sew the bronchus, I usually never cut the bronchus and use a perioperative bronchoscopy to assess and cut it. And if that is not feasible, on the table, we can even debulk the tumor by fulguration, by a snare, and remove it also. So we have to be very, very careful in selecting patients. And as I again emphasize, you should not get into a stage where you have two cut ends of the airway, especially in the thorax. Neck, you can get away with a Montgomery T tube. which you can join together. So this needs very proper planning and surgery.
May I
Thank you,
make a
Dr.
may
Rajan.
I make a
There's not
comment,
much
please?
of a debate, and we conclude this session. Both of the speakers have agreed that central tumors in a fit condition, a fit patient, and surgically, although surgically challenging, but in a good center where surgery is feasible, the first option would always be surgery for central tumors. So we would conclude that, and then we'll go on to the next talk, that is functional lung imaging for radiation planning for lung cancer by Dr. A.K. Anand.
Thank you. Am I audible now? Yeah.
Yes, very much.
Yeah. So thank you very much, the organizers, which are our host institute, for giving me this opportunity. I think they've changed some slides. This thing. Previous one was okay. My slides, please.
You can run from your own computer.
Okay.
Previous slide was your introduction.
Okay. Okay. So I'm going to speak on another aspect of lung cancer treatment. We had the previous session on early lung cancer, and in early lung cancer, it has its own problems of achieving a very high cure rates and also preserving the lung function. But in locally advanced lung cancer, it is I think. So I don't know, I'm not visible on the screen.
So you are visible and you are audible also. We can see your presentation.
Yeah, we can see your slide.
So in locally advanced lung cancer, the big challenge is a big lung mass, which we have to treat, stage 2B or stage 3. And most of the patients will receive a radical dose of radiation and most of the time concurrent chemotherapy. So radiation, as we know, plays a very important role in both small cell and non-small cell lung cancer. And concurrent chemoradiation is indicated in both in locally advanced stages. And it plays a role in curative treatment. In early stage, we have seen SBRT, but in locally advanced cases, concurrent radiation and chemotherapy is the standard of care. Although neoadjuvant chemo followed by surgery and radiation is also practiced in stage 2 and stage 3. And therefore, the challenge always remains how to give a tumoricidal dose, which is in the range of around 64 to 66 gray to the primary tumor, and yet save a meaningful lung so that the patient should not have lung toxicity after the treatment. So stage 1, we have discussed, and SBRT has achieved good results, and especially in the peripheral small cell lung cancer, you can see healthy lung is protected, and we have very defined beams, very precise beam radiation dose delivery. So the rest of the lung, even in medically inoperable, challenge, comorbidity patients, we can deliver a tumoricidal dose and yet achieve a high cure rates in the vicinity of 80%. And you can see one of our patients with SBRT showing excellent results at 4 and 9 months with virtual disappearance with very little fibrosis. The lucky one, but some of them have local fibrosis as well. This is the one patient who had local fibrosis even with SBRT, and it is well known that this kind of fibrosis persists for a considerable period of time after SBRT. And then how we grade these radiological changes from a mild fibrosis or a patchy consolidation to a diffuse consolidation. And so these are the things which will be discussed in one of the subsequent talks. But the real challenge comes when we treat locally advanced cancer patient, and it is, you can see here, there's a big tumor. Red is the gross tumor volume, then we draw a CTV along with ITV, and then there is a PTV. And you can see the underlying lung. There is a partial collapse here, and then there is a air here, and then the other lung. So the real challenge is, out of, even if we have to spare this lung, we do not know which part of the lung is real healthy from the perfusion and ventilation point of view. And therefore, if we have this lung and we are protecting upper lobe, which was the one which was not that much compromised, and we sacrificed the lower lobe, which was the only part of the lung which had adequate ventilation and perfusion, and we pass our beams from here, that patient will have problems of radiation pneumonitis and breathlessness. So therefore, if we are protecting opposite side of the lung, we also protect same side to some whatever extent possible. But in the opposite side, we have to know whether the upper lobe or middle lobe or lower lobe, which part of the lung is perfusing well, which part of the lung is ventilating well, so that we make all efforts with our beam directions so that we spare the functioning lung more compared to the poorly functioning lung. And I will show you some pictures how we can do that and give better results. Now, same another patient, you can see locally advanced lung cancer treated with radical dose of radiation with or without chemotherapy. And you can see you have to save this part of the lung, you have to save the other part of the lung. So which part we should save? Because we cannot treat this with the high doses and yet do not give any dose to the normal lung. Normal lung will receive some dose. This is just benefit for the surgeon. And we have to compromise between the tumor dose and dose to the normal lung. We all know that for locally advanced lung cancer, it is the concurrent chemoradiation which is the treatment of choice, and it is preferable over sequential. And you can see the multiple trials here. The concurrent chemoradiation giving overall survival benefit of, you can see here, compared to sequential, which gives inferior survival. And yet I see in our country still a lot of patients undergo neoadjuvant chemo followed by surgery or radiation, which according to me should be discouraged. And if you see now the NCCN guidelines for the last 2-3 years, concurrent chemoradiation followed by durvalumab is the level 1 evidence and the standard of care for locally advanced non-small cell lung cancer. And this is borne out by these multiple trials, which all show the concurrent chemoradiation is far better than sequential neoadjuvant chemotherapy followed by radiation. In some centers, they say there is a waiting time and therefore we do neoadjuvant chemo. I don't think that holds, the argument holds that good. Concurrent chemo RT should be practiced if we have to achieve the best results. But concurrent chemotherapy, chemoradiotherapy also has these complications, which we should be aware of, which I was talking about, grade 3 and 4, pneumonitis and esophagitis. So if we are able to know which part of the lung we spare, and we do our best effort to spare the normal lung, we will be able to give a good dose, a tumoricidal dose, along with chemotherapy, and yet keep the grade 3 and 4 pneumonitis and esophagitis to the minimum level. So we say that is concurrent chemotherapy is always superior. Although I have shown the data, it is always superior. But no, in some patients where 2D radiotherapy or suboptimal sequencing, and if we use big volumes in our radiation portal, then the toxicity of concurrent chemoradiation can give counterproductive results. So we have to be very choosy. As we are choosing in surgery, we have to be also choosing in selecting patients for concurrent chemoradiation. Now here we have to have an individualized approach to chemo RT for the benefit of surgeon, but radiation oncology understand all that. But for the benefit of surgeon, if we are unable to achieve volume of the lung receiving less than 20 gray to less than 35%, then we can practice concurrent chemo. So if we are able to save the lung adequately, concurrent chemo radiation is very good. It gives good results and with very few complications. However, if our dose to the normal lung is exceeding, here it is exceeding, it's the red box, then we should discourage concurrent chemoradiation. Then maybe we can give 2 cycles of chemo, reduce the lung mass, and then give maybe concurrent chemoradiation after that.
Dr. Anil,
So what kind of lung injury we see with radiation? So the significant lung injuries we see in 2 parts. One is ventilation defects, other is perfusion defect. Ventilation means if the air is entering the alveoli adequately in some part or whole of the lung. And the perfusion means the blood supply reaching those areas. So how to find out which part of the lung is well ventilated and well perfused? So radiation-induced lung injury occurs in biphasic manner, as we all know that earlier in first 6 months we can have an early inflammatory pneumonitis, and if it remains uncontrolled, it can progress to late fibrotic phase, chronic radiation toxicity in the form of fibrosis. However, fatal pneumonitis occurs in less than 2% of the patients treated with curative radiotherapy, but symptomatic radiation pneumonitis can occur in about 20 to 30% of patients, and therefore the need for functional lung imaging. Now, this is the thing I was talking about, how to determine ventilation volume. And there are various techniques. Some people use 4D CT scan. Some people, we have used in our institution, ventilation perfusion scan from Sept in nuclear medicine. So this is the one publication which they have used the free breathing computed tomographic image volume. And this you can see is the gross tumor volume, and yellow means 90 percentile, means at this height 90 percentile, you can see only this much yellow part is ventilating well. However, if we increase the percentile, you can see suboptimally, you can see the green volume is ventilating more. And at lower values, 30% percentile, then a lot of lung is working well. So therefore, our aim should be this, that we should be able at this or at this point, this much lung on the left side and this much green area on the right lower lobe should be spared as much as possible, because this is the functioning lung. We can sacrifice maybe this lung along with the tumor dose, but save the left lung and the lower lobe of the right lung as much as possible.
Can you conclude in 1 minute, Dr. Anand?
Yeah, so it's the last 1 or 2 slides. So it is now, you can see the planning. This is the planning which is done without a ventilation scan. You can see the opposite lung is receiving high dose. However, if we use the ventilation scan and we cut down the dose to the left lung, now the dose is confined to the right side. And so this is one of our patients which we did in nuclear medicine. You can see this orange area means very well perfused lung, ventilated lung, and the pink is partially functioning lung. So inside lung is working well, and the peripheral part is functioning less well. So what then we can do is, this is a fully functional lung, and the pink is partially functioning lung, and on this side. In this side, you can see in these that this lung is working well, and the upper lobe here is also not working well, and therefore we can sacrifice this part and preserve this orange part of both sides of the lung. So this is what we did. We saved this left side of the lung, orange and pink you can see, and the doses were delivered through the right side, and we tried to spare the lower part as much as possible. And you can see here the dose delivered was, which we needed about 63 gray, which we could achieve. And you can see here the V5 with the fully functional, you can see 58, and the V20 also with fully functional 10 gray, and the mean lung dose 9.8 gray. So you can see here that if we know where the lung is to be protected, we can achieve those doses and achieve better results. So this is a very good publication has come, done a systemic meta-analysis on functional imaging in radiation oncology. And according to this, functional link imaging may have potential utility in radiation therapy planning and delivery, although significant heterogeneity was identified in approaches and reporting, but this is a science in progress and we should utilize wherever possible. So take-home message is meticulous radiation planning is needed for patients with lung cancer to deliver this dose, especially in concurrent RTCT protocols. Unexpected lung toxicity may occur despite adequate sparing. Therefore, even if we achieve good V20, V5, we sometimes see unexpected toxicity because we don't know whether we save the normal functioning lung or abnormal functioning lung. So functional lung imaging would help in further reducing lung toxicity due to radiation in patients with lung cancer. Thank you very much.
Thank you, Dr. Anand. I do not see any question on the question chat box or somewhere. I think we'll go with the next lecture, and then maybe some questions are there that we'll take. Now, next lecturer is Dr. Vinita Goel. She's a senior radiation oncologist from the Max Hospital. She is going to speak on consolidating primary in metastatic non-small cell lung cancer, who, when, and how. Dr. Vinita, and if any questions are there, please put it on the question answer here, so then we'll take it later on. Thank you. Dr. Vinita, please.
Good evening, everyone. I hope I am audible. I request Dr. Anand to kindly stop sharing his screen so that I can start sharing my screen.
Yes, ma'am, you can start share. Start sharing, please.
So I hope my screen is visible. So I will be talking about consolidating primary in metastatic non-small cell lung cancer, who, when, and how. So I think this topic is quite deep because here we are not talking about giving palliative radiation therapy for pain, bleeding, airway obstruction, etc., which are all well-recognized indications of radiation therapy in metastatic situation. So the point that I'm trying to answer today, the issue that I'm addressing today is consolidating radiation therapy to primary disease, even in the setting of metastatic lung cancer, when majority of the patients are asymptomatic for the primary disease. So first of all, I would like to ask this question, is this topic relevant? I think this topic is quite relevant because metastatic non-small cell lung cancer represents a big subset of patients. 50% of the patients who have non-small cell lung cancer have metastatic disease at presentation. And even patients who have locally advanced non-metastatic disease have predominant pattern of failure in terms of distant metastatic disease. So this forms a big subset. Additionally, if you look at the pattern of failure, even in patients who have metastatic lung cancers, this is a study which included approximately 400 patients who had metastatic lung cancer. And after first line of chemotherapy, they looked at their pattern of failure. And the predominant pattern of failure was persistence of the safe metastasis or the local disease in the patients even after systemic therapy.
Dr. Vinita, your slides are not moving.
Oh, is it?
Go to the second slide and then pick it.
Okay. So I had started from here that, are they moving now?
No. We are not seeing the slide. We are just seeing the red line.
Okay. Is it visible now? I'll stop sharing and start sharing once again.
Yeah. Yeah, we can
Yes,
see.
ma'am, now it's.
Yeah.
We can see now, ma'am.
Okay, thank you so much. I'm sorry for this glitch. So I was saying that metastatic. So I'm talking basically about consolidating radiation therapy to primary disease in metastatic setting, even when the patients are asymptomatic for it. And the reason why this topic has probably been chosen by the organizers is because metastatic non-small cell lung cancer represents a big subset of patients. And even the pattern of failure studies have shown that even in the stage 4 disease, majority patients continue to fail wherever they start their disease from. For example, if there's a patient who's got carcinoma of left lung and with 3 metastases, even after chemotherapy, they continue to have local residual disease in those sites. They might get another metastasis, but those sites, they tend to persist. But let me also remind you that metastatic non-small cell lung cancer is not a single disease. It's a spectrum. Patients can have solitary metastasis, they can have oligometastasis, they can have polymetastasis. Metastasis may be synchronous or metachronous, and within that also they can have short or long disease-free interval. Even the primary disease can be N0 or N plus or T1 to T4 disease, and the driver mutations may be present or absent. So when I'm talking about metastatic non-small cell lung cancer and when you are talking about metastatic non-small cell lung cancer, we might be talking about a different spectrum here. Even within the oligometastatic disease, we know that it is again a spectrum. Patients can have synchronous disease, metachronous disease. They might have oligoprogression or oligopersistent disease. So there is a wide spectrum of disease within this also. Fortunately, AJCC 8th staging has also recognized that oligometastatic disease is a separate subset, and M0 disease and M1 has been further classified into M1B, into single extrathoracic metastasis versus M1C, which is multiple extrathoracic metastasis, reflecting that oncology community is gradually realizing that there is a paradigm shift in the management of metastatic disease, and we are moving away from the classical teaching that M1 means non-curable. Although the fallacy is that the biomarkers are yet to be incorporated in this staging system. So when we talk of oligometastasis, we all know that this was proposed by Hellman and Bischelbaum in 1995. And oligometastasis represents an intermediate state where there are a number of metastasis and destination organs are limited. We know that metastasis occurs in stepwise manner. Initially, there is limited disease followed by widespread disease. And we are trying to nip the disease when it is in the oligometastatic state so that we could offer cure to some of these patients. Unfortunately, we have high sensitivity images like PET-CT and MRI, which help us in identifying this oligometastatic state well. There is a lot of confusion about how to define oligometastatic disease. Majority studies have included up to 8 studies have included up to 8 metastases as oligometastasis, but majority studies restrict up to 5 metastases. EORTC lung group has defined that up to 5 metastases in up to 3 different organs are to be considered as oligometastasis. Here, mediastinal lymph nodes are not counted as metastatic disease. Astro and Istro think have proposed that 5 metastases is fine, but what is important is the ability to deliver safe and clinically meaningful radiation to all metastatic sites as the definition of oligometastasis. So the present definition of oligometastasis is based on the numerical value and imaging, and the biology and genetics are still to be incorporated. And when we talk about giving radiation therapy to the local site in oligometastasis, we are trying to achieve a potential cure because we know by the pattern of failure studies that these patients ultimately, majority of them, they progress in these sites. And we are also trying to achieve immunomodulation and abscopal effect. So if I have to summarize my first 10 slides, the point that I'm trying to make is that let's not put all metastatic non-small cell lung cancer patients in one bracket. We must identify patients with oligometastasis with good biology. So going forward, I will take you through some studies which have shown the advantage of local consolidative radiation therapy. This was one benchmark study which came in 2016 from MD Anderson, which included stage 4 lung cancer patients with less than 3 metastases, up to 3 metastases. All kind of non-small cell lung cancer patients were included in this. All patients were treated with frontline up to 4 cycles of chemotherapy or EGFR or ALK inhibitors. And following that, they were randomized into either maintenance therapy versus observation or local consolidative radiation therapy or surgery with or without maintenance therapy. The type of local consolidation radiation therapy was decided by the MDT, but the trial had an early closure after accrual of about 49 patients because this interim analysis showed that the median PFS in the arm receiving local consolidative radiation therapy was almost 3 times of the arm getting only the maintenance therapy, 3.9 months versus 11.9 months. Now, the same study have published their results after a longer follow-up of approximately 3 years, 38.8 months. And now it shows that there is a definite PFS advantage, and also there is an overall survival advantage. Look at the overall survival advantage in the arm receiving local consolidative radiation therapy. It was 17 months versus 41.2 months. So this impressive overall local survival advantage was achieved even in the absence of immunotherapy without any major toxicities. Now, this study, which I showed you just now from MD Anderson, included all comers. It had EGFR mutated as well as non-mutated lung cancer. There's another small study which excluded patients with EGFR and ALK mutation. Patients who had stage 4 lung cancer with limited metastasis were treated with 4 to 6 cycles of chemotherapy. Patients who had partial response or stable disease and up to 6 extracranial metastases were given consolidative radiation therapy with SPRT, and again, the similar outcome. This study also showed that the arm which was receiving patients who were receiving SPRT, apart from the maintenance chemotherapy, had a progression-free survival which was almost 3 times that of the arm not getting local consolidation radiation therapy. There's another interesting retrospective analysis from MD Anderson, which included large number of patients, close to 200 patients, up to 3 metastases, who were given standard of care systemic therapy plus local consolidative radiation therapy. This trial again showed that there was a PFS advantage in the patients who received local consolidative radiation therapy, but it also showed in subset analysis that patients who had squamous histology compared to adeno, patients who had higher T stage, higher N stage, or bony metastasis, they did worse than their counterparts. So there are several ongoing phase 3 trials which are currently accruing patients for this consolidation radiation therapy. So my second message to the audience at this point of time is that there are several phase 2 and retrospective data which have shown that there is a PFS, and some have also shown OS advantage when local consolidative radiation therapy is added to primary as well as metastasis in metastatic non-small cell lung cancer, although we need to be careful in selecting our patients. Now let's come to another subset of metastatic non-small cell lung cancer, which is EGFR mutated carcinoma lung. We know that EGFR is one of the key drivers, and they have better outcome than non-mutated non-small cell lung cancer. And the standard treatment for the EGFR mutated lung cancer is EGFR TKI. But ultimately, majority patients will develop acquired resistance after 9 to 14 months of TKI therapy. And let's look at the role of local consolidative radiation therapy in EGFR mutated non-small cell lung cancer. So this is one study, which is a retrospective analysis again from MD Anderson. So patients who had EGFR mutated lung cancer, stage 4, were treated either with first-line TKI or first-line TKI plus local consolidative radiation therapy. And this included metastasis up to 3 in number. This study also showed that there was a significant PFS advantage when local radiation therapy was added to TKI. And in fact, you can see that the median overall survival is not yet reached. Now, somebody can say that this study had very small number of patients. There were only 12 patients who got local consolidative radiation therapy. So let me show you another study. This study comes from China, around 230 patients who were treated with either TKI alone or TKI plus local consolidative radiation therapy. And for local consolidative radiation therapy, they were given all mixed kind of radiation therapy with gamma knife, cyber knife, etc., etc. And this study also showed that the patients who got local consolidative radiation therapy had a better progression-free survival as well as overall survival with the addition of radiation therapy. This benefit was regardless of the type of mutation. This benefit in PFS and OS was regardless of the type of metastasis in bone, brain, or lung metastasis. So the point number 3, the message that I'm trying to give you is that patients who have metastatic non-small cell lung cancer with either EGFR or ALK mutations, they benefit with local consolidative radiation therapy irrespective of the type of mutation and organ of metastasis. Another situation that we often come across is oligoprogression, when majority of the metastases are controlled with the systemic therapy, but 1 or 2 metastases are progressing. So this is another study, old study. It started in 2012, where stage 4 lung cancer patients who had oligoprogression after platinum-based chemotherapy, irrespective of their EGFR status, were given local consolidation radiation therapy, and they reported a median PFS of 9.7 months and overall survival of 20.4 months when the local consolidation radiation therapy was added. There's another study.
These are 2 minutes left.
Okay, sir. So there's another study which looked at the patients who developed acquired resistance to EGFR TKI, and when radiation therapy was added, the patients could continue on the same EGFR TKI without progression for a long time. We all know that ultimately all patients with EGFR mutation develop T790M acquired mutation, And even on osimertinib, they developed this mutation and resistance. So this is a study which looked at the patients, 14 patients who were on osimertinib progressing, and they were given local consolidative radiation therapy. The progression-free survival was way better in these patients, and they could continue osimertinib for a longer time. So another point that I'm trying to drive home is that patients who have TKI resistant and oligoprogression also benefit with local consolidative radiation therapy to primary as well as metastatic sites. We know that oligometastasis is a spectrum in itself. This IPT meta-analysis also helps us in categorizing our patients of oligometastasis into 3 categories. They found that the overall survival was best when the oligometastasis occurred in the metachronous setting. It was intermediate when there were synchronous metastases, but the patient had N0 disease, there were no mediastinal lymph nodes. And it was worse when the patient had synchronous metastasis with N1 to N2 disease. So we can use this kind of substratification in optimally selecting our patients. Immunotherapy is the new buzzword in the management of metastatic non-small cell lung cancer. And these are the result of Pembro-RT phase 2 trial, which have shown that patients who had oligometastatic disease, when they were given SBRT low dose, 8:3 fraction, they had almost doubling of their overall survival as compared to patients who were not given this radiation therapy. So now this has also been accepted and incorporated in a lot of guidelines. This is ESMO guideline, which says that stage 4 patients with 1 to 3 synchronous metastasis at diagnosis may experience long-term DFS following systemic therapy and local consolidative radiation therapy. They have also mentioned that stage 4 patients with limited metachronous metastasis may also be treated with radical local therapy. Patients with driver mutations with oligoprogression may also be treated with radical local treatment. So my last 2 concluding slide to answer the question, who are the candidates who benefit from consolidating primary in metastatic lung cancer? I will say patients who have good performance status with oligometastatic non-small cell lung cancer. Up to 5 metastases is what is accepted. But a word of caution, majority of studies have used only up to 3 metastasis patients. So maybe in a regular clinical setting, we can stick to up to 3 metastases. Patients who have driver mutations present, patients who have oligoprogression or EGFR inhibitors. Another question is when to give this consolidative radiation therapy. Ideally, we have to give minimum 3 to 4 cycles of 3 to 4 months of systemic therapy before starting consolidating radiation therapy to look at the aggressiveness of the disease. And so far studies have shown that it is safe to combine radiation therapy with targeted therapies concurrently with due caution. And how? We have various options like radiation therapy, surgery, RFA, and cryoablation. Radiation therapy has an edge over other techniques because it is non-invasive and it is a precise treatment. One can choose to use SBRT, hypofractionated RT, or conventionally fractionated RT, keeping in mind that we should be able to give radiation with adequate BED. Minimum BED required is 60 gray and preferable is up to 100. Thank you so much.
My compliments to you, Vinita. Wonderful presentation.
Thank you, sir. One more last point which I wanted to make was that all these patients have to be discussed in democratic, multidisciplinary tumor board before starting anything without dominance of any surgical or medical or radiation oncologists. Thank you.
Thank you, the speakers and co-chairpersons and the organizers for giving this wonderful opportunity. Dr. Shanti Vastava.
Thank you, chairpersons, and thank you, speakers. So now we move forward to the next panel discussion, which is to be moderated by Dr. Naveen Mumudi. Interpreting CT scans after SBRT, when to do biopsy. Dr. Naveen Mumudi is Assistant Professor Radiation Oncology at TMC. Over to you, Dr. Naveen.
Hello and welcome everybody. Good evening to one and all. I'll start by thanking the organizers for having me here, and also I thank the organizers for choosing a very often under-discussed topic. So let me start. Yeah, can you stop your slide sharing, please?
Dr. Naveen, you need to invite your panelists.
Sure, I'll do it from my slides. Okay, so I'll do the obligatory. Can you hear me and can you see my slides? So as I said, this is an often under-discussed topic, interpreting CT scans after doing such heroic stereotactic body radiation, and also to discuss when to do biopsy. We have eminent panelists amongst us. So we have a mix of well-stocked panelists. So Dr. Ananda Selvakumar is from Madurai. He's a senior radiation oncologist. So is Dr. Shika Goyal from PJ Chandigarh. Dr. Anand Moidar is a radiologist from Max Hospital, Saket, and Dr. Abhishek Gupta is a senior nuclear medicine physician from Max Vaishali, and Dr. Abhishek Bansal is an intervention radiologist from Rajiv Gandhi Cancer Institute. So we have a very balanced mix of panelists amongst us. So we are going to discuss what are the side effects that we commonly see after stereotactic body radiation, namely radiation pneumonitis, and how to differentiate that from patients who have local recurrences. So as we had seen in the last couple of talks, SBRT has become a major force to reckon with in the last decade or so, in especially early stage non-small cell lung cancer, who are medically inoperable, and also some equipoise in patients who are operable also. More often than not, patients who have oligo disease, like Dr. Vinita just concluded in her talk, patients who have oligometastatic disease or oligoprogressive disease or oligorecurrence are also being increasingly treated with SBRT. So the control, especially with early stage patients, has been excellent to the tune of 90% local disease control and loco-regional disease control of about 85%. However, this also comes with a slight cost, in the sense the toxicity that are associated with SBRT are not too frequent, but still nevertheless they are there. The most common of all these side effects are radiation pneumonitis, chest wall and skin toxicity, brachial plexopathy are seen in peripheral tumors, but not so common in other tumors. So as I said, most of these side effects are radiation pneumonitis, but they are rarely severe, and clinically most patients are asymptomatic, and incidence is in the range of 8% to 10%, especially the grade 1, grade 2 pneumonitis. So my question to my fellow panelists, Dr. Ananda and Dr. Shika, can go sequentially. Before we go into dealing with how to identify these complications and how to go about them, would you briefly tell us the different ways that you would take to avoid these complications, namely radiation pneumonitis? Dr. Ananda, if you can go first.
I would like to start with the tumor size. Better to choose the right tumor size, under fractionations. Along with that, appropriate introduction of steroids can lessen the chance of these pneumonitis kind of.
All right, Dr. Shika, regarding the treatment technique, is there anything that you would be careful while planning these patients?
Regarding the treatment technique, we would ensure that the basic goal of doing SBRT is that you minimize your target volume. So you do not, you select a tumor which is not too huge. Tumors more than 5 centimeters will entail a higher risk. Then we do not give a PQV margin, only a PQV margin. And we try to minimize that PQV margin also by using some sort of motion management, either in the form of abdominal compression or in the form of breath holding, DIBH, or some kind of tumor gating or trapping. And when planning, we have to take care that we use low energy beams, which is 50 megavolts. We do not use energies more than 10 megavolts. Try to avoid beam entry to the opposite lung as far as possible. Use non-coplanar arcs or beams as far as possible to reduce the spillage into the contralateral lung, as well as the spillage, reduce the spillage into the important central structures as well. Multiple beams will need to be used, or even beam at arcs are okay. And we have to take care of the high dose spillage as well as the intermediate dose spillage. So the volume of lung receiving high doses, or the dose to the lung more than 2 centimeters away from the target, they should be seen during the planning phase and controlled as well.
All right, so all valid points. So in addition to all those factors that Dr. Shika just mentioned, there are few factors, both patient-related and disease-related, that you should be looking out for. So, other than the size, we should also see what the patient's performance state and age is, because it is seen that patients who have advanced age are more prone to develop these radiation pneumonitis, especially if they have any underlying ILD, or if they were smokers who had severe COPD. These are patients who are more likely to end up having all these side effects. Regarding disease, if you had a lower lobe lesion, possibly because of your diaphragmatic movement, the larger tumor expression, again, these patients can develop radiation pneumonitis. And as Dr. Shika just mentioned, you'll have to be careful when you're doing your radiation planning. Be mindful of the V5, V20 and MLD. Make sure they are minimum to reduce the complications. So coming to the outcomes, so after we have planned an excellent SBRT and we have delivered it to the patient, most often patients, when they fail, they are going to fail outside the field. It is seen that almost 50% of these patients will have isolated distant recurrence, but also a small percentage of patients do have local regional recurrences to the tune of 10%. If you look at isolated local recurrences alone, literature quotes about 6%, and if you look at only isolated regional, that is nodal recurrences, it is about 8%. So although these numbers do not seem to be too huge, what we need to remember is that the more number of patients that we are going to treat in the future, we are going to have a lot of patients who come back with such isolated recurrences, and we need to be mindful of the fact that these patients may be candidates for salvage therapy and they may be potentially curable, and also the fact that if we do not treat these patients, they might end up having some morbidity or mortality because of the disease itself. So to illustrate this, let me take you through a case history. So this is a 76-year-old patient who is hypertensive, who otherwise was in a good general condition, who presented to us in 2015 with soft tissue mass which is measuring about 2 into 3 centimeter and a high SUV. So this lesion is in the right lung lower lobe, and the biopsy of this came out to be adenocarcinoma, and we staged the patient as T2 N0 M0. So this is the plan that we did. This is the contouring that we did after 4D CT, and we did a rapid arc with 2 hemi-arcs on the right side. So my question to the radiologist, I'll begin with Dr. Anandmoyi. What is the usual follow-up imaging practice that you would do at your center? All right. Can I ask Dr. Ananda and Dr. Shika to go? When would you image your patients first after they finish their SBRT?
For the first 2 years, it's going to be 3 to 6 months. I prefer CT. Then after 2 years, it's going to be every 6 months.
Dr. Ananda, my question to you is, when would you do your first follow-up imaging after your SBRT? The first imaging that you do?
12 weeks. 12 weeks.
All right. So you would do it about 3 months. Dr. Shika, any difference of opinion, or do you agree with him?
I agree with him.
Yeah, so 3 months. And Dr. Ananda, as you said, you would prefer to do a CT scan.
Yes.
Is that right? Any specific reason for doing a CT scan and not a PET CT scan?
PET CT, I prefer to do a PET CT after 6 months. It's my kind of protocol.
Okay.
For the initial 6 months, I do prefer a CT, unless there are no symptoms in view of distal recurrence.
All right. Okay. So as we know, most of these patients who undergo SBRT, be it early stage or even the oligo patients who receive SBRT, the common pattern of failure would be actually distant recurrence. So although if you do a CT thorax, it should cover most of the lung and the liver where patients generally fail. Some institutes do believe in doing PET CT scan. I would invite the radiologist in the panel, Dr. Abhishek. Would you like to weigh in there and tell about what your opinion is about?
So again, as I was rightly said, our protocol is the and our protocol is from 8 to 12 weeks again, not from 1 months. And we want to get PET CT during the first 6 months because of the high tech restoration training. But yes, once we have something needs to be worked up further, then PET CT comes in.
All right. Okay. Dr. Abhishek, would you do any specific parameters when you're just doing a CT thorax? Anything specific that you would look for in these scans, or is this a normal usual CECT thorax that you would do, especially in patients who undergo SBRT?
Yes, so it's just a routine normal CT scan we would want to take during a venous phase so that we are able to look at all the vessels and all the neighboring areas.
All right. Okay. And you would prefer to do this in breath hold, right?
Absolutely. So as a routine, all CCT chests are done in breath holds, and so we don't need any special protocol for a CCT chest.
All right. Great. Okay. So if I can bring in Dr. Abhishek Gupta here, what is your opinion about PET CT scan? Although all the panelists agree that they wouldn't do a PET CT scan till it is 6 months, what do you think are the pros and cons of doing this, Dr. Abhishek Gupta?
So, whatever the studies have been published in literature, so they all have recommended a PET CT at a minimum time of 3 months. That's 12 weeks. That is when all radiation pneumonitis, if any, would have settled. And then they have asked for a repeat scan at 1 year. And what they have correlated is that whatever findings you are going to find on a 12-week scan, approximately 80% of them will correlate with your 1 year PET scan finding.
Yeah. All right. Yeah, sure. So the worry in doing a PET CT scan too early is that many of the changes because of radiation, especially all this inflammation because of radiation, may persist, leaving false positive reports, which might necessitate doing unnecessary further investigations, including a biopsy. So that is the reason we would try to postpone the PET CT scan as late as possible. However, we need to also remember the fact that since many of these patients are prone to developing distant metastasis, delaying it too late might actually make us lose out on some window where we could actually intervene and do some investigations with these patients. All right, so this is coming back to the same patient that we discussed. So this is the pre-SBRT imaging of this patient, the right lower lobe lesion. And when we did a CT scan 3 months post SBRT, so this is the image that we saw. There is some response. In fact, we did a PET CT scan for this patient at 3 months because that's our protocol. And there was a good metabolic response in this patient, as in there was reduction in the metabolic activity, and also radiologically there was some decrease in the mass. So I would like to have the opinion of Dr. Abhishek Bansal now. What would you think about these scans? So these are the 3 months and 6 months SBRT scans. So would you like to comment on these?
So these are the part of the lung changes that we see post SBRT, and we can divide them into acute and the late changes. So the acute one, the consolidation part and the ground glassing is the most common one, and this is how it evolves normally into fibrotic sort of a thing with the traction bronchiectasis.
Yeah.
So
we could see, in fact, in 3 months we could hardly see too much of changes, but when it was 6 months, we could appreciate all these pneumonitis changes, which became more prominent by the 14 months, with also the patient developing some pleural effusion here. So would you consider this as a red flag?
So again, isolated pleural effusion is not considered a red flag. So you need to correlate with other findings, and especially on the ipsilateral side. So I would want to rather wait and then.
So that is exactly what we did in this patient, but subsequently after 6 months, she had slightly a further increase in the pleural effusion, which we did tap this time, and that turned out to be malignant cells on the pleural effusion, and based on which she went on further to receive systemic therapy. So she had a local failure at this point of time. So coming back to another case, this is a 76-year-old male who had history of COPD, who presented with chronic cough, otherwise was in good general condition. So this was the lesion this patient had in the right upper lobe, which is a 2.2 centimeter node, and with some hilar nodes which showed mild uptake on SCV, and they were deemed reactive. And we went ahead and gave SBRT to this patient. So the biopsy was keratinizing squamous carcinoma. This is a contour, and this is what we planned. So at 3 months, again, very similar to the previous patient, this was the scan that we saw in this patient. And at 7 months, this is what we saw. Dr. Anandmay, would you want to comment on this 7 month and a subsequent?
Yeah, we can see there are changes seen in the 7th month, which is typical of fibrosis, conventional modified fibrosis. We can see there are architectural distortion along with loss of volume and some bronchiectasis which is seen. And not a very significant change over a period of time
Yeah.
is seen. It is quite stable.
Yeah, as you rightly said, so this remained stable for almost 3.5, 4 years, and this patient did not have any recurrence and is doing currently well. So, coming to another case, this is a patient who had a left side lower lobe lesion which was close to the chest wall. We gave 60 gray in 8 fractions, considering that this is close to the great vessels. And this is a patient who presented at 3 months with a reduction in size of the lesion, but at 6 months he developed some consolidation in the left lower lobe. So, would you comment why he had a why he had a collapse consolidation? Any of the radiologists?
Yeah, it can change over a period of time, and we can see progression from 6 months to 12 months, and even beyond that, up to 2 years, that is 24 months. There could be progression. So, and we can see from 18 to 24 months, it is remaining stable. There is no further progression and change in size and all that.
Yeah.
So,
So the development of consolidation, would it be a reason because this patient has a lesion which is close to the bronchus here in the lower lobe bronchus? So possibly because of radiation, there was some stenosis which happened within the bronchus that led to further collapse. So this
yeah, so
patient
there was a
actually, yeah,
collapse.
yes, yeah. So for other than the collapse, this patient did not have any progression features of progression, so he continues to be all right. So let me get back to my radiation oncology colleagues. So what is the difference in between the conventional fractionation and SBRT with regards to their post-treatment imaging? Would you agree that there is some difference in the pattern of pneumonitis that we see in both these cases?
The pneumonitis is not that severe in SBRT part than that of conventional fractionation that I can see. The toxicity is very less with SBRT protocols than that of conventional.
Yeah, agree. Dr. Shika, would you care to share your opinion?
Radiological changes after SBRT start much later compared to what they are with conventional fracture. So with SBRT, they start after 4 months, usually progress around 8 months into
So
chronic.
that's absolutely right. So you generally have patients developing pneumonitis slightly later in SBRT, and also the fact that after conventional RT it is more extensive compared to SBRT. Also after conventional RT you generally see that the 40 gray, 50 gray volume completely developing pneumonitis, but in SBRT it is the higher dose, the 60 gray, which is actually would the PTV volume which would actually develop into radiation pneumonitis. So there are two distinct phases in radiation pneumonitis: acute and late. Acute is generally up till 3 months, and chronic is after 6 months. And these changes, the pathological changes, are reflected in the radiological features, as Dr. Anand Mohi was mentioning. So there are distinct, different changes after SBRT that you see early and late. These are the 4 early changes and 3 late changes that have been described. Dr. Anand, would you want to describe these for us quickly?
Early changes can be of the one of the 4 patterns. It could be a diffuse consolidation, which is commonly seen, or a patchy consolidation, like we see in the top 2 images. Or it could be a diffuse ground glass opacity or a patchy ground glass opacity of less than 5 centimeter in size. And fibrosis can be seen as modified conventional fibrosis, or mass-like fibrosis, or scar-like. In modified conventional fibrosis, we see an area of consolidation with loss of volume with bronchiectasis.
Yes.
While in mass-like fibrosis, we can see a lesion which may be larger than the original lesion, but it is stable over a period of time, and it may give a fallacious appearance of a mass. And in a scar-like fibrosis, we see a linear, irregular fibrotic scar.
Yeah. Dr. Anandmai, can you describe these slides that you have in front of you?
So these are diffuse consolidation, which is seen, which is typically seen within 6 months of therapy, and they are the acute changes. The most common pattern is a consolidation pattern. We recognize this as an increased attenuation with air bronchogram in the region of original in the tumor bed.
Yes, and how would you call these changes? So there's a
Yeah.
patient who had
So we can
SBRT
see
and
the
after 3
lesion
months.
prior to treatment, and following treatment, there is a focal area of ground glass opacity and patchy consolidation.
All right, okay. And the diffuse and patchy, your cutoff is 5 centimeter. Is that right?
Yes,
All right.
diffuse is much more bigger in size.
Yes, and these are again ground glass
The
opacities.
ground glass opacities, because we can see the underlying lung markings and bronchi within it. A consolidation is much denser. And this is a more diffuse pattern of ground glass opacity because it is involving an area larger than 5 centimeter. So these are the 4 patterns we can see.
Okay, and how would you rate this?
Yeah, this is a modified conventional fibrosis pattern, like I was describing, a pattern of consolidation along with bronchiectasis. We can see the air-filled bronchi within it, and this is an important sign because filling of these bronchi would mean that there is some recurrence happening. The margins are sharp, and there are changes of loss of volume.
All right, so this is also something similar to that modified consolidation, and this is a mass type, as Dr. Anandmai was mentioning, and this is a scar type fibrosis that you would see. So all these, it is very important to recognize that these are normal and they are not any high risk features suggestive of disease recurrence, as opposed to these changes which have been classified as high risk features. So these 7-8 features have been called as the high risk features. Dr. Anandmai, would you take us quickly through this?
What are the few features that we need to look at to know that a recurrence might be happening? These are the air bronchogram which were earlier there and suddenly they disappear, or the margin which was sharp and lateral margin may start bulging. That means the tumor is growing. Or if there is a growth in the craniocaudal length, which is more than 5 millimeter in size, or after 12 months, if we see sudden enlargement, and that enlargement is sequential. In sequential scans, we see the opacity to be enlarging. Or if the sharp linear margin suddenly disappears and we can see irregularity or bulging appearance. And if there is a new pleural effusion which happens and which occurs after a particular interval.
As seen in this patient, so there is an increase in size, so which was after 2 years, which was more likely to be recurrence and not because of radiation pneumonitis. Again, in a patient who, after 6 months, the fibrosis had kind of stabilized, but after 3 years, we see new changes which are high risk features. So these high risk features we need to keep in mind, but there are also certain differential diagnoses. Dr. Shika and Dr. Ananda, what are the differential diagnoses that you would want to rule out before labeling a patient to have a disease recurrence? And how would you differentiate them?
Like infection is more common in these patients. Apart from that, any subclinical interstitial disease may come out. They could, this kind of disease, yeah.
Correct. Yeah. So before labeling something as a disease progression, we should remember that many of these patients are prone to have concomitant infection, especially tuberculosis reactivation, which is common in our country. Also, because many of these patients are chronic smokers who have COPD, exacerbation can also cause symptoms which might symptoms and radiological features which can mimic disease progression, but they have different temporal and also certain difference in their radiological picture. So we should always keep these things in back of the mind before we label somebody as disease recurrent. So Dr. Abhishek, again, I would want your opinion on, so we said we are going to do a PET CT scan 6 months after the patient has finished radiation. So how would you interpret those imaging?
So if you go for a SUV cutoff, there is no absolute value for any SUV cutoff. So there have been certain publications which have put up a SUV of say 5 in a 6 months, or actually it was on a 3-month scan, and they say that the specificity of 94 to 96%, if it is less than 5, it is more in favor of radiation than being lungs. And there have been publications between SUV 3.2 to 4, which says the specificity increases to around 97%. But for all practical purposes, what we check is compare the SUV value of the lung lesion versus the liver. If it is more than liver, then it becomes a suspicious lesion.
Yeah. And also the fact that you would want to know what the SUV was, the pre-treatment and post-treatment. So if there is a significant increase, you would label. As you rightly said, there are a lot of cutoffs, but one of the cutoffs that has been quoted by many papers is that SUV of more than 5, which does show that it is recurrent.
There have been many other features, values, which we calculate on a pre-SBRT PET CT scan. So initially it was only the SUV max, now is SUV mean.
Yes.
Then we have metabolic tumor volume and total lesion glycolysis.
Correct.
Total lesion glycolysis is metabolic tumor volume multiplied by SUV mean. So the higher the values, braver the prognosis, earlier the chance of a recurrence.
And Dr. Abhishek, quickly, are there any other radionuclides that you would consider in addition to FDG PET CT scan, or would you just stick on to FDG?
Plenty of them at the moment. What we are being used in India is F18, FLT or fluothymidine.
Yeah.
So sensitivity is a bit better than FDG PET, but the isotope, the
Availability is.
lasers which are being are gallium based. So gallium based FAPI or fibroblast activated protein inhibitors, which was the image of the year last year in 2019, and gallium based pentisexfo.
All right. Okay, so that's great. So there is
Dr.
also some.
Naveen,
Yeah.
You have 2 minutes left with you.
Yes. So generally, after we see these high-risk features, when they rise a red flag, we need to be sure. Depending on the number of high-risk features that you see, there is a nice algorithm by Huang et al. Who published this in 2015. So if a patient has more than 3 features, then you would label them a high suspicion of recurrence, and then see what their salvage options are. But if there are only 2 features, you might consider doing a PET CT and taking it up, depending on the uptake value. So the interventional radiologist, would you like to do an FNIC or a biopsy in these patients?
So always a biopsy. It's because FNAC might be non-diagnostic.
Correct. So and although biopsy has certain complications, these most are minor. So we still would like to do a biopsy because that will give us adequate tissue, which would help us plan our further salvage surgery. So let me quickly run through this. Also, patients who are receiving SBRT, as we saw in the previous lectures, people are now getting immunotherapy, and these can also lead to changes in the lung. We should always remember that increasingly we are going to see these patients, so we need to interpret these scans with the background that immunotherapy can also cause some pneumonitis, and we will have to look at that factor also. So Dr. Shika and Dr. Anand, your last question. So salvage therapy, when would you consider in these patients after you prove that these patients have recurrence? So the whole point is to see whether they are salvageable. So when would you consider them for salvage therapy, and what kind of a treatment would you choose?
If we had taken up the patient, taken up a operable patient, we can ask the help from surgeon, the lung surgeon. If that is not a operable case, we can try re-SBRT also.
Yes. And in patients who are not fit for SBRT or surgery, you can consider them for thermoablation,
systemic therapy.
RFA or cryotherapy, and if they have disseminated metastasis, or if they are not fit for anything, systemic chemotherapy or best supportive care alone. So there are a lot of literature on this, where patients, especially from MD Anderson, where salvage surgery and salvage SBRT has been shown to give good local control and survival benefit to patients, and they have kind of developed a nomogram as to when to select which patient would go on to receive what kind of a salvage therapy. I'll just summarize this by saying that patients who have a local recurrence are still candidates for salvage SBRT or salvage CTRT, depending on their general condition and performance status. So radiomics is also coming up a big way. I will skip this and go to my last slide. So SBRT, their high ablative doses are given. So toxicities are rare, but they're a little difficult to manage. Serial imaging, as the panelists mentioned, are very important. PET CT scan, you need to choose the right time that you would want to do, and also you always need to keep a high index of clinical suspicion. Biopsy from primary can be done in some patients if it is going to make a difference in your further management, but you should always weigh the risk and benefit of these patients. Some of these carefully selected patients would be candidates for salvage therapy, and they would benefit from that. Thank you so much. Thank you, panel members, for your useful information that you have given. Thank you, organizers, for this opportunity. Thank you.
Thank you, Dr. Naveen. That was a good and informative session. So to move forward to the last session of Hall B, I now invite Dr. Sapna Nagia, who ma'am is Senior Consultant, Radiation Oncology at Apollo Proton Cancer Center, Chennai. Over to you, ma'am, please.
Good evening, and thank you very much for inviting me to chair this session. It's my pleasure to invite Dr. Srinivas Chilkuri, who will be discussing the role of proton therapy in lung cancer, and it is his, he's the only one in the country right now with the experience in dealing with this, and it's my pleasure to welcome him to deliver his talk. Dr. Chilkuri? Yeah.
Are you able to see my screen?
Yes, we are able to see your screen and we are able to see you.
Thank you, Dr. Sapna, and thank you, organizers, for the opportunity. My job is for today evening is to discuss proton therapy for lung cancers. Before I talk about why proton therapy can be considered for lung cancer, I would like to illustrate a case. This was referred to us a few months ago. A 63-year-old gentleman from Mumbai was diagnosed with squamous cell carcinoma and was staged as T3N3M0. He was a diabetic and hypertensive and weighed about 120 kgs, and this was his tumor in the left side upper lobe, and it was staged as I mentioned, T3N3 after bronchoscopy and PET-CT and the biopsy. It was planned very well with intensity moderate radiation therapy, and what we found interesting was the V20 was noted to be about 36%, which is definitely higher and which puts him at risk of nearly 1 in 2 risk of having grade 3 radiation pneumonitis. V5 was more than 60%. The mean lung dose was close to 20 gray. The hard dose, mean hard dose was nearly 30 gray. So definitely a good plan as far as IMRT is concerned, but definitely something which would put him at a very high risk of radiation pneumonitis. So what would one tell such patients? Typically, one would quote a result of RTOG0617, assuming that we are able to reproduce the outcomes as was found in RTOG0617. The median overall survival would be about 28 months, which is a few months short of 2.5 years, with a 5-year overall survival of 32%. Local failure, nearly in 1 in 2, regional failure, 40%, distant failure, nearly in 60%, 2-year progression-free survival, 30%. So just remember this figure, 2-year PFS of only 30%, so 70% progress approximately. And this is not a number to be proud of, definitely. And despite this dismal outcomes, the grade 3 toxicity is between 75 to 80%. So more than 4/5 of patients, we are giving grade 3 toxicity with a 2-year progression-free survival of just about 30%. So definitely nothing to be proud of. And the fact remains that not just the dose and rest of the things, but the dose to heart is actually impacting the outcomes. The volume of PTV is impacting the outcomes. The maximum related esophagitis or dysphagia grade is impacting outcomes. That means clearly the OIR dose is contributing to the overall survival. So it's not just toxicity, but overall survival. So this is something of a concern. Of course, this was in pre-immuno-oncology era. We have now the latest PACIFIC results as recent as ESMO 2020. The median survival improving from nearly 2.5 years, as mentioned in RTOG 0617, to nearly about 4 years. And despite that, the high rate of radiation pneumonitis is still observed in durvalumab because it does contribute to a little bit of pneumonitis, nearly 1/3 of them having radiation pneumonitis. So apart from radiation pneumonitis, there is now a major emphasis on cardiac toxicity as well. Initially, it was considered as a late effect. In lung cancer, it is hardly of concern because it would happen after 5 to 10 years. Very few patients survive. It's a major concern only in patients with known cardiac risk factors. But unfortunately, it's not true. The cardiac events begin much earlier than 5 years, and the effect is seen regardless of known cardiac risk factors. And multiple studies have shown that the median time to develop a cardiovascular effect, side effect, toxicity, grade 3 or above, is just 11 months. So a lot of arrhythmias, pericardial effusions, myocardial infarction. So not just grade 3 toxicity, but a significant proportion also have mortality. And the mean heart dose has been known to correlate with cardiac events at 4 years, and more than 20 gray is nearly, again, 41%. And this gentleman who is obese, who has certain risk factors, with a mean heart dose of 30 gray is definitely, I would not push him for concurrent chemoradiation. So is the mean heart dose the most important structure or parameter? We know, I've seen this title, and I love saying this, meaningless meaning of mean heart dose, because it's probably there are many more structures or many more parameters which are as important. Pulmonary artery, is it probably the base of heart, which is probably the most radiosensitive structure, which corresponds to sinoatrial node. So we know, we are still learning the cardiac dosimetry and which is the most radiosensitive structure. And in this situation, it's imperative to save as much heart as possible. With this background, I mean, I've built a reason why proton beam therapy can be considered. We all know the physical advantages. We all know the Bragg peak, which is definitely a physical attribute of protons, but not just physical advantages, but there could be biological advantages. The RBE, which is considered as 1.1, which is 10% higher than the X-rays, which is as a blanket figure, is not true. It ranges from 10 to 70%. So there could be areas in Bragg peak where the RBE could be as high as 1.7, which is 70% higher than conventional X-rays. Not just physical and biological advantages, there could be immunological advantages, especially in the thorax or the mediastinum, where a significant cardiac and peripheral circulation is radiated. And therein you see that the drop in lymphocyte count, not just because of chemotherapy, also contributed by radiation, the higher the lymphocyte count fall, the lower is the overall survival. So several groups have demonstrated that the fall in lymphocyte counts is directly correlated with the overall survival, not just in lung, but esophagus and many other mediastinal structures, not just mediastinal structures, even quoted to be seen in even brain tumors. So uniformly speaking, despite the older generation passive scattering proton therapy, most of the studies have shown that the hard doses are significantly lower with proton therapy compared to IMRT. So this is again another reason or rationale to consider proton therapy in certain group of patients. We know that the passive scattering is an older generation proton therapy technique. There are multiple limitations. It is not a really efficient system. It is not even the most conformal system. Compare that to the intensity modulated proton therapy, which we currently use at Apollo Proton Center and most of the new modern proton therapy facilities across the world. And because of this change, you can see that thorax is now one of the probably one of the most common reasons why proton therapy is being used in North America. So this is typically the distribution between IMPT and VMAT, where you see the low dose spillage significantly quite a bit compared to proton therapy, where you see that the majority of the anterior structures, cardiac substructures are clearly spared. So there have been multiple phase 1, phase 2, some single arm, some comparative studies. Of course, all these were analyzed in a national cancer database analysis with all the limitations of a retrospective analysis. This study showed that the proton therapy was led to a better overall survival compared to a non-proton therapy, any technique used with a hazard ratio 1.21. And when they segregated the stage 2, stage 3, which constituted probably the unresectable, inoperable ones, there also they showed that the hazard ratio was in favor of proton compared to non-proton therapy. This is in all lung cancers. There have been multiple studies, again, phase 1 and phase 2, which have seen the evaluated role of proton therapy in stage 1 lung cancers as an alternative to stereotactic body radiation therapy, just like radiation therapy, SBPT, or hypofractionated, ultra hypofractionated proton therapy. Those studies have also shown that proton therapy led to a better overall survival and progression-free survival. And this was, they called it as a hypothesis generating meta-analysis. With a better outcome, they also found that the grade 3 to 5 toxicity was lower. Significantly, radiation pneumonitis was lower with proton therapy, but the chest wall toxicity was higher with protons as expected. So that led to a randomized trial, phase 3 randomized trial, which was published many years ago. Actually, this was a recent update of it. It is a Bayesian adaptive because there were a lot of logistic issues. It's not a clear cut phase 3 design to make it more practical. It had multiple questions being answered, whether dose escalation is required, dose escalation is feasible, is proton better? So multiple questions asked in this complex design, whether the patients were suitable for 74 gray delivery. If not suitable, then they were put into 60 gray, 66 gray bracket, and then were randomized. So there was multiple complexities. And you can see that 19 patients who actually were denied protons due to insurance. So only 75% who were randomized to protons actually received it. 23% of patients for whom protons were the only acceptable plan received IMRT. So there were a lot of issues. This is a small randomized trial, of course. And the biggest issue is exclusively all patients were treated with passive scattering proton therapy, and they used large safety margins, which led to larger high dose regions. And the results found that there is no difference in local control or high grade treatment-related pneumonitis with proton versus photons. Of course, uniformly, as I mentioned, the cardiac doses were less in patients receiving proton beam therapy. And not only that, there was a clear learning curve. So that means if the trial was divided into earlier half and later half, the earlier half, nearly 25% of patients had radiation pneumonitis compared to none of them in the second half. That means there was a learning curve in the proton patients receiving proton beam therapy compared to IMRT, where there was no learning curve, which is quite expected because proton therapy actually started at MD Anderson Cancer Center, where this trial was conducted in 2010, and immediately within the same year, this randomized control trial was initiated, and there was clearly a learning curve as far as radiation planning was concerned. And that is why we have multiple proton lung trials now, both phase 1, phase 2, phase 3 randomized trials comparing proton and photon, both in stage 3 inoperable unresectable setting as well as in stage 1 when as an alternative to SBRT. Of course, there are certain uncertainties and concerns related to proton therapy. There are some physical and some biological uncertainties. Most of them we have kind of trying to learn to address them in a big way. Standard physical uncertainties could be mitigated by using robust optimization in Monte Carlo. None of the patients were robustly optimized in these studies. None of them had Monte Carlo, which we are routinely using. So what was tested and evaluated was an yesteryear technologies. Radiobiological uncertainties can be addressed significantly by using LET-based evaluation. We need to address interplay effect. Of course, we have now rescanning techniques. We treat patients in breath hold to limit the effects of interplay in these patients. Of course, proton therapy is definitely not suitable for patients who have large erratic motion. Of course, and most of the patients do require adaptive treatment you need a daily imaging, and based on that, you need to take a call when adaptation is required. Cost is a major concern. There is no doubt about it. And that is the reason why we need a judicious patient selection. We cannot blanket recommend this treatment for every patient. We need to really understand which group of patients would really benefit out of it. And with the coming down of the footprint of proton therapy, hopefully the cost also could come down. So coming back to the 63-year-old gentleman, we treated with proton beam therapy. This was the old IMRT plan, and what we saw was clearly there was V20 came down from 36 to 22%, mean lung dose from 20 to 12 gray, mean heart dose 30 gray to 7 gray, a significant reduction. Even V5 of lung came down from 61 to 35%, which has now becomes an acceptable and in fact a very good plan for this particular patient. And thereby we have treated both patients in central locations, in upper lobes, in the lower lobes. So we have treated a few patients now both in a re-radiation setting as well as in upfront in radical chemo-RT setting. We have treated in all of patients of all locations. So to conclude, proton therapy has a definite dosimetric advantage over IMRT in lung cancers. And this dosimetric advantage extends to tumors in most locations in lung. it could have reduced the rate of pneumonitis and cardiac toxicity. Now, most of the studies are uniformly showing that the rate of pneumonitis and cardiac toxicity is lower. Early results as far as the large retrospective and National Cancer Database and a meta-analysis of retrospective studies, which I've shown, is encouraging with low toxicity outcomes. Of course, the cost remains a concern, and that is the reason why we need to judiciously select patients. Safe dose escalation through proton SIB and hypofractionation is being tested in combination with concurrent chemotherapy in multiple phase 2 and phase 3 trials in North America. So with this, I conclude my presentation. Thank you.
Thank you very much, Dr. Srinivas. I think that was very clearly elucidated the benefits of proton therapy in lung as far as pneumonitis, heart, lymphopenia, as well as the promise of dose escalation. I hand the proceedings over to Dr. Charu for further.
Thank you, ma'am.
Dr. Sapna. Can I take a quick question, Dr. Prekshi?
Yeah, ma'am, sure.
Dr. Srinivas, just wanted to ask, what is the role of proton in SBRT? Where does it stand as of now?
So SBRT, in the sense, if you do an ultra hypofractionation in stage 1 or stage 2 lung cancer, or T1 or T2 lung cancers rather, there is a role. In fact, there is a definite advantage of, there is meta-analysis of those retrospective studies. Of course, there are multiple limitations of those retrospective studies. Most of them have not been comparative studies, but they clearly show that there is a benefit of protons, even dosimetrically. I also showed the immunological benefit. That means the lymphocyte lymphopenia, which is associated with SBRT, could be significantly reduced. So there is a physical, biological, and immunological advantage even in the setting of ultra hypofractionation in stage 1 T1, T2 lung cancers. And that is the meta-analysis which I showed. It was, of course, a hypothesis generating. It needs to be tested in a randomized controlled trial setting, but there is already an evidence emerging that this could be an alternative to SBRT. So Charu, I hope that answers your question.
Great. And the results you showed for that 62-year-old gentleman. Over to you, Dr. Prekshi.
Sorry, Dr. Charu, 62-year-old gentleman.
Charu, we missed your comment.
Okay, I said that answers my question, Dr. Srinivas. And the case which you showed, that was really exciting to see the lung doses and the heart doses coming down so drastically.
Yes.
So I think proton is going to be a big player in coming times. I think at present,
I think we lost you again. We lost you again.
Internet connection is not.
Yeah, the connection is not
stable. Over to you, Parikshi.
Yeah, okay. So thank you, Dr. Sapna. Thank you, Dr. Srinivas. So any radiation oncology talk will not be complete now without proton. So now we wrap up the session for Hall B today. I now request everyone to please move to Hall A. We have a very interesting ongoing session there. And I also request everybody to join on 3rd of October, that is next Saturday at 4 p.m. to join again NALSICON the 3rd day. So please move to Hall A.
Thank you.
Thank you.